going to be looking at breath work, but when we come to look at the unique breath technique that we do, the apnea breath, the reason you have this picture is because when you see an apnea breath on the internet or in visual pictures generally, it will look like perhaps the picture on the far left in the middle, or perhaps the pictures in the middle. They might look more like those. Now, the pictures at the top and the pictures at the bottom are all also perfect apneas. The apnea itself is a creating of a vacuum, which I'm going to talk about in more detail. However, the reason that people have different shaped apneas when they do this is one, body weight. Two, it depends on how big the central tendon of the diaphragm is, on how much draw they get for the vacuum, or how much opening they get with the vacuum when drawing up. I'll come back to that. And also, it depends on the size of their rib cage. So if they've got a phenomenally large rib cage, then they're going to get this kind of across the middle. Whereas the ones at the top and the bottom have different shaped rib cages that reflect, that mobilize their muscle chains and their fascia in a different way, in a similar way, but not so dramatic. So sometimes I have to show my clients mine, because mine looks much more like the middle at the bottom. Possibly. It's maybe not as dramatic even as that. it's probably more the middle on the right. So mine's not flashed all over the internet because it's, it doesn't give people the wow factor, but it certainly helps to lift my pelvic floor and create function. So what I say to my clients is, please don't get hung up on what you've seen. Get hung up on what you feel. So the benefits that we have for hypopressives, these are some of them. There are many more as well. So it enhances your posture. It makes you more aware of your posture and how you're holding your body all the way through the day. It alleviates back discomfort and strengthens the core. There's actually more research done on it for unspecified low back pain than there is for pelvic floor dysfunction. So we definitely know that there's a real correlation between the working with the quadratus lumborum when we're working, so the big back muscles and the paraspinals, and that helps to alleviate any pain in the thoracolumbar fascia, which is the big crosshatch of fascia at the back of your spine in your lower back. It promotes a balanced resting tone. So we're looking for great resting tone in our body, so our body's ready to spring into action when it needs to and is prepared for that. It enhances lung capacity. The breath work that we do is really well researched. Slow breath work is really, really well researched now. It boosts athletic endurance. So we create better tolerance for CO2, better Boreflex, which increases our athletic endurance. It enhances intimacy and sexual satisfaction. This is a big one for my clients. Quite often they're like, I get the best orgasms ever now, Abby, which is great. And we should talk about that more often. This is because of better blood flow to the pelvic floor, primarily, but also better activation of the pelvic floor and creating a more functional pelvic floor that doesn't carry too much tension so that it can release and tighten when you have an orgasm. It's also remembering the fact that the vagina itself is a muscle. So the more kind of work we do around that whole pelvis area, and with our fascia, which we'll talk about a little bit more today, but also tomorrow, or in another coming fascia course, how important it is just to keep that activated too. So it promotes a functional pelvic floor. So I'm not looking for a tight pelvic floor. I'm not looking for a pelvic floor that carries tension at all. I'm looking for a pelvic floor that's functional, that has great resting tone. And that's really important because our pelvic floor has to have great contractile ability, but also great extension ability as well. So we're looking for it to be able to eccentrically load as well. When we sneeze, cough, etc., our pelvic floor actually widens, so it eccentrically lengthens. So we need it to be able to do that and do that with strength. And in order to be able to do that, it needs to not be held tight all the time. It reduces anxiety and stress. So a lot of my women, one of the reasons they have pelvic floor dysfunction is because they're stressed or they're anxious. And the stress and anxiety came first, then the pelvic floor dysfunction. Sometimes the pelvic floor dysfunction came first, then the stress and anxiety, then the pelvic floor got worse, and it becomes a self kind of prophesizing circle. And it also improves lymphatic drainage. And we'll talk about that a little bit with the rib cage, the activation of the rib cage and the lymphatic system. Okay, so that's some of the benefits. There are loads more that people report to me, but these are the ones that we can prove. So yeah, that's where we're at. So a little bit about the history of hypopressives. So Uddiyana Bandha is a yoga exercise, and it's, you know, historically the one where people see an apnea breath, the unique breath, and they go, oh, I've seen this before. This is in yoga, it's something Bandha, and I'm like Uddiyana Bandha or Nauli. So when people sometimes come to me after watching on the internet, they've often self-taught themselves it like an Uddiyana Bandha. And I'm going to explain why the Uddiyana Bandha is different from what we do in a moment. Right now, actually, I always forget where I am in these things. So Uddiyana Bandha is a lock to tighten and control the thoracic area of the body, and is often taught as a drawing inwards and upwards of the abdominals after a forced exhalation. It is then held. So when you're doing an Uddiyana Bandha, you inhale, you exhale you try and exhale all your air. So a forced exhalation is trying to exhale all your air really quickly, like a and then they pull their abdominals inwards and upwards. Now, I am never going to ask my clients to pull their abdominals inwards and upwards. What we're working with instead is we're working with activating the rib cage, the thoracic area of our body. And if the abdominals look like, I'll spin back so you can see the picture. If the abdominals look like this is not because they've pulled their abdominals inwards and upwards. This is because simply they've widened their ribs. So what's happened is, as they've widened their ribs, the obliques, the transverse and everything have responded to that, but something else is happening here too, which we'll talk about when we come to do it. And I might flash back to this picture again at that point, so you can witness what's actually happening. What we're looking for, and what you'll see here with all these pictures, is that the belly button is being drawn up a little, and that bit is going to become more important and more obvious to you in a moment. So we're going to learn how different the breath work is in hypopressives. There is here a little video of the Uddiyana Bandha so you can see it. And then when you do your apnea breath, you'll understand why it's different. So I'll play this for you. Look at his belly button and his posture when he does it. Okay, there are benefits to it, and the same similar benefits we get from hypopressives. Now, you could see his belly button was just being pulled inwards and upwards. It wasn't like it was being drawn upwards. So that's a significant difference between what we do and what is happening in Uddiyana Bandha. So the bandha is usually done with a throat lock too, called a jala bandha. So they also curl the throat in. So everything kind of curls in and then lifts up, like everything's been curled into it, like a sea curl almost, but without, you know, sea curls are done slightly differently. So these are the things that Uddiyana Bandha do that also hypopressives also do, without having to do that pull in. We strengthen the abdominal muscles and the diaphragm. We massage the abdominal viscera, the solar plexus, the heart, and the lungs. So we're going to talk about how that happens when we do our breathing in a moment. We improve gastric fire, which is how the yogis talk about it. We look at also digestion, so the assimilation and elimination. And also we purify, so this is the lymphatic drainage, the digestive tract of toxins. We stimulate blood circulation in the abdomen and blood flow to the brain. And there's a massive thing about blood flow to the brain now, and how breath work helps to cross the blood-brain barrier. And how that helps with things like Parkinson's, and they're looking into it as research for things like Alzheimer's, Parkinson's, and Huntington's disease. So it's the next stage in research towards those illnesses. It stimulates and lifts the energy and unites it with the navel. So we're going to look at how we stimulate that with our breath work, which is slightly different. By the way, guys, if you've got any questions as we go through, please don't hesitate to ask. Yeah, just pause me if you need to. So traditionally, so the first time we actually see a proper abdominal vacuum, the way we do it in hypopressives, is in bodybuilding. So Arnold Schwarzenegger and Bruce Lee are both doing an apnea breath here, but they're doing it for a different reason. They're not doing it to create a lift within their pelvic floor. They were doing it to show off the serratus anterior muscles and their upper thoracic area. So they used to use it during competitions, and Bruce Lee used it during movies to show how powerful he was as well. So the abdominal vacuum has been popular in culture for a long time and has been used in both abdominal training and bodybuilding. The action of creating a vacuum through the use of an expiratory breath and then a costal opening can be used to show the definition of the surrounding muscle groups. It can also be used to tone and strengthen the deep transverse abdominis and the obliques. So this is what sells hypopressives, more than selling it for the pelvic floor. In South America, my colleagues in South America, they advertise hypopressives as being able to shrink your waist, because the more you can widen your rib cage, the smaller your waist becomes. And they get loads and loads and loads of women through the door for that reason. The pelvic floor exercises, as they're traditionally given out to women by physiotherapists, not all physios, but the majority of physios, were invented or created by Dr. Kegel. Now, he's not a bad guy at all, and I never say that, he is. It's just that his approach doesn't suit everybody. He was first introduced his pelvic floor exercises way back in 1948. He had done an 18-year study. This guy studied 18-year study of the pelvic floor, urinary incontinence, and pelvic organ prolapse. He brought his findings that women and men could activate and strengthen the pelvic floors through a series of squeezes differing in intensity, which we all know of nowadays. The Squeezy app does it too. But even he didn't think that just telling women how to do them would work. And he invented his Kegel pyrometer, which is a little bit like the Kegel-atus today. Ta-da! You could all say, yeah, Abby, that's great. Why are we even here if this has solved all the issues of pelvic floor dysfunction? But did he? The issue with Kegels is that they're often embarked upon with little or no clear instructions. They do very little for women who have stress incontinence and very little with women who have overflow incontinence. So both of these things are caused by too much tension in the pelvic floor. They work sometimes for women with urge incontinence, but urge incontinence tends to be more of a neurological urge incontinence comes in because women are worried about what's going on with their pelvic floors. So urge incontinence starts to be triggered by things like putting your key in the lock, or needing to get to the toilet because you've arrived somewhere. So the first thing you do when you arrive somewhere is you need to go to the toilet. So the brain triggers that response. You need to go to the toilet now, we've arrived here. Or we're at home, you need to go to the toilet now. And actually, for urge incontinence, bladder retraining actually helps really well with that. So I will talk a little bit about that too. Kegels are often embarked on with, usually women just think, oh, I've got pelvic floor dysfunction, I'm going to do Kegels. And they often do them really, really wrong. In places like Belgium, France, women get a pelvic floor physio to see them for minimum 6 sessions after they have their babies, or if they're having issues, so not even just after babies. And the pelvic floor physio will teach them how to either do a Kegel or use a Kegelizer, and will be there to guide them, which is something that we just don't get in the UK at all. And then the pelvic floor physio decides whether they need to do Kegels or not. And oftentimes, especially in Belgium and France, if they don't need to use Kegels because perhaps they're carrying too much tension, they're given hypopressives. So hypopressives are the go-to. And also in Spain now, almost all physiotherapists have at least done a little mini course on hypopressives. So this leads to the muscles we're trying to get to being overlooked as we over-recruit our hip abductor muscles, abdominals, glutes instead. So women will use their hips, they'll tilt the pelvis while they're doing their glutes. While they're doing the pelvic floor exercises, they'll squeeze their glutes instead of their levator ani muscles. They'll use their abdominals to try and lift. So it just starts creating an issue with timing overall their body. Again, ask questions if you need to. So a really clear example of this is this, and it's not about the Kegels so much, but it's about a mistiming, training yourself into mistiming. A lot of my women come to me, and then when they go to the toilet, because they're so worried about having an accident when they're out and about, that they will lean forward and they will squeeze all the last of their urine out. So they start using their abdominal muscles, their transverse muscle and their obliques to squeeze their bladder, instead of allowing the muscle that goes round their bladder, their detrusor muscle, to do the work. So the detrusor muscle, which might be timing a bit slowly because they're quite, all over the place, and I'll talk, yes, okay, I'll explain. So I'll go a bit slower because I'm going, I've got so much to tell you. So your bladder needs you to be balanced in your nervous system. So your bladder uses both your sympathetic nervous system and your parasympathetic nervous system to work. So when the bladder squeezes, when it's emptying or voiding and squeezes, this is a parasympathetic, this is the sympathetic nervous system squeezing. But then it needs the parasympathetic nervous system to open the urethra. And then it works the opposite way around. The sympathetic nervous system squeezes as the parasympathetic nervous system allows the detrusor muscle to expand. If a woman is anxious and stressed out, she's going to be more in her sympathetic nervous system. So that means that the opening of the urethra will be dysfunctional. So the parasympathetic nervous system will not necessarily be working in time with the sympathetic nervous system. So then they go to the toilet and they're really worried about wetting themselves, and they're becoming more and more anxious about all of this. So they're getting more and more in their sympathetic nervous system. And then they're on the toilet, they're worried, they're stressed out, they're squeezing. And their bladder and their urethra aren't working in time with each other, so they use their abdominals instead. So their abdominals start kicking in and squeezing their bladder. And then I do like hypopressives with my ladies, and they're talking, and I talk about going to the toilet, and they tell me they're doing this. And we talk about when they leak the most. And they leak the most when they walk, when they run, and when they walk upstairs. And in all of these positions, they're recruiting their abdominals. So every time they recruit their abdominals, their body goes, hey, she needs to pee now. And their body responds and pees. So if we can also, alongside what we're doing with hypopressives and any other pelvic floor work we're doing, if we can also teach women to relax on the toilet, to take their time, to breathe and not squeeze. So the instruction I give them is that when they go to the toilet, I want them to wait till their body starts peeing, till the detrusor muscle does its job. And then I want them to wait at the end. I don't want them to rush off the toilet super quickly. I want them to wait until they can feel their body doing its natural squeeze at the end. Their pelvic floor doing it, not their abdominals. And after a series of time, they find their leakage gets less, much less intense. And some of them, it just stops altogether. And actually the issue wasn't all the other stuff. The issue was that they trained themselves really to use their abdominal muscles instead of their detrusor. So it's something to think about, alongside everything else. So Marcel Caffrey's came along in the 1980s, and he is a postpartum gynecological and he works in re-education and research. Marcel observed that the pressure exerted by the thoracic diaphragm, together with a weak parietal resistance, were the cause of vaginal hernias or vaginal prolapses. So it was a combination of the parietal fascia and the abdominals, the compliance of the abdominals and the thoracic diaphragm that was causing leakage. Likewise, he discovered the antagonistic postural relationship between the serratus anterior, these muscles up here, and the thoracic diaphragm. So that when tensioning the serratus, a thoracic expansion was provoked, while a tonic relaxation of the thoracic diaphragm was provoked, which caused a decrease in intra-abdominal pressure. We're going to experience this, so don't worry, it's all very wordy, but I'm actually going to do it with you in a moment so you can feel it. In this way, the beginning of Hypopressive techniques emerged, defined in his program as the diaphragmatic aspiration techniques. Now, Marcel Caffrey's will only train physiotherapists. He wouldn't train me. He wouldn't train me. He was like, "Oh, you're a personal trainer. I'm not interested." He will only train physiotherapists. So along comes, So along comes low pressure fitness. But low pressure fitness, Tamara and Pitty used what Marcel was teaching, and they went and did his courses. But they also used some other practitioners with their ideas and brought them all together into what's called hypopressives, of the hypopressives that I teach now. So Françoise discovered that certain muscles intertwine, resembling tiles on a roof, creating what she called muscular chains. So this is where the term muscular chains comes from, this idea that there's a fluid chain that connects between the adductors, say in the inner thighs, through to the obliques and onwards. So there's chains through our bodies of muscle chains that work in combinations with each other. These chains harness a remarkable collective strength, the cumulative power derived from each individual component. It is this formidable force that leads to distortion, stiffness, joint immobility, compression of intervertebral discs. In essence, our musculoskeletal issues and poor posture stem not from muscular weakness, but from compressive forces generated by persistent contraction and shortening of our muscular chains. And this is what happens within the pelvic floor as well. But the pelvic floor, issues with the pelvic floor can come from because of issues with your posture as well. And we'll talk about that when we come to that stage in this course. The Françoise method employs innovative and nuanced neuromuscular techniques, incorporating distinct postures. A lot of her postures are used in hypopressives. So a lot of the posture patterns come from Alexander technique and Françoise. She also used a specialist breathing approach, which is similar, and hands-on intervention from the therapist. So if you can be in a room with somebody while you're teaching them hypopressives, all the better, because the tactile cueing is super important. The primary objective is to reduce the surplus muscle tension consistently and present in the muscular chains. This reduction facilitates the body's transition toward a significant enhanced shape and posture. Consequently, musculoskeletal issues causing pain tend to fade away. And the same with pelvic floor. The more we can get people to feel much more balanced in their bodies and to decrease tension patterns, the better their pelvic floor becomes. The pelvic floor is part of a team, and it's really important that the whole team is working well in order for the pelvic floor to work well. Additionally, there is a beneficial side effect as weaker muscles, like those in the abdomen, front of the thigh, gain strength. So, the muscles that aren't working so well gain strength, while the tight muscles release and become more functional. The other work that is also used within hypopressives is from Philippe Souchard. He was a French physiotherapist in 1980. This manual therapy approach revolutionized the understanding and treatment of musculoskeletal disorders. It was a comprehensive analysis of anatomy, biomechanics, muscle physiology, neuromuscular coordination, and it was very innovative for the time. So he looked at how repetitive movements inherent in daily tasks, as well as demands from work and sports activities, necessitated prolonged postures, which contributed to a shortening again of the muscle fibers, rendering them less amenable to stretching. So he saw that this impeded fluid movement, altered posture, and induces imbalances in joints. And so again, the techniques that we use in hypopressives, some of them come from Philippe as well. And these are little pictures of, this is of Françoise working with somebody, so working with their rib cage orientation, which we're going to talk about. And this is one of the postures we use in hypopressives. So low pressure fitness. So low pressure fitness is what I first trained with these guys when they called themselves hypopressives. And they combined everything together. So they made it so that it was a program which used much more movement than Marcel Caffrey's uses. Marcel Caffrey's is quite really static in his poses, and we've got much more movement. And combined that with Philippe Souchard and Françoise as well. They have since become low pressure fitness, or LPF, and they train mainly in Spain and abroad, but are a little bit in London now too. All the trainers within the International Hypopressive Council all started with them, but then we created the International Hypopressive Council so that we could develop hypopressives further with all of our combined knowledge together. So we've got people who are physiotherapists, international gymnasts, me, all of us together. What we're doing is we're progressing hypopressives even more, adding new stuff in that works really well to actually create more of a fluid engagement of the pelvic floor. So Pitty and Tamara trained with Marcel Caffries. They saw that hypopressives could have benefits beyond physiotherapy clinics and could be learnt and taught by specialists in women's health. They developed a more dynamic movement-based protocol, bringing in the ideas of Francoise and Philippe. I should have just read that because, you know, it was much shorter than my explanation. Okay, wordy. So the method you are going to be learning is based on all that has come before. It has been enhanced by the continued review and additions added by all of us at the IHC. We are all international trainers, and so that Hypopressives could become a multidisciplinary tool. So we've changed it from saying you just need to do Hypopressives on its own, like low pressure fitness, and what we would like is for you to be able to embed it in your modalities. So we'd love you to be able to add this into your Pilates classes, or your physiotherapy, or your the osteo work that you do, and we'd like you to be able to add it in and seamlessly sew it in. So it doesn't need to be a separate entity. It can be, you can use the key components and add them into what you do. So it's more about gaining an understanding of how the connections between all these areas work so that you can add them into what you do already. So we're not very precious about it. We just would love better care for women with pelvic floor dysfunction. So let's get to different breathing patterns. Before we do, and before we talk about this, and before you even look at that screen, I'm going to come out of the share for a moment, if I can find my wee thing. Okay. And I'd like you to take a moment. Hi, everybody. I would like you to take a moment and notice your own breath. I don't want you to think about it. I just want you to notice it. And I'd just like you to take some breaths, and I'd like you to think about a couple of things as you're breathing now. So just bringing your attention to your breath. I'd like you to think about what you breathe through. Do you breathe through your nose or your mouth? Do you inhale through your nose or your mouth? Do you exhale through your nose or your mouth? I'd like you to notice when you're breathing whether you find that you've got quite a tight jaw, quite a tight neck. I'd like you to notice whether you're primarily breathing with this kind of upper area of your body, or you're breathing primarily into your belly, out towards the front, or that's the important, it's out towards the front, or whether you're actually using your rib cage when you're breathing. And I'd like you to also notice when you're breathing, whether you notice anything else in your body. Do you feel that your back feels tight, your shoulders feel tight? What do you feel? And take a few other breaths. Now, you guys all teach exercise, so this won't be the same as when I ask women who have never done anything before in their lives. But these are kind of questions I ask them, you know, because I want to know, I want them to bring awareness to themselves first. So, how many people inhale through their nose? Out of you guys, show of hands. Cool, good. And how many people exhale through their nose? Cool. I'm going to ask you to do something different today, but I'm going to explain why as well, though. But exhaling through your nose is brilliant. How many of you had jaw tightness when you were breathing? Okay. That's why we're going to breathe differently today. So we're going to talk about that. How many of you experienced feeling of tightness in your shoulders when you were breathing? Okay. How many of you were primarily breathing kind of with this upper section of your body? Okay. How many of you were primarily breathing out into your belly at the front? Interesting, good, okay. And how many of you were using your rib cage laterally and all the way around like a circumference? A few of you, okay. Cool, well, we're going to talk about this. So we're going to look at what the predominant breathing patterns are. I'm going to go back to sharing, and then we're going to talk about how we're going to change that to make it better for your bodies. I'm just going to make sure I'm on the right screen. That one. Who knows? Okay, so we're back. Okay, so different breathing patterns. The epical breath, which is upper chest. So we'll just call it what it is. It's the upper chest and neck movement. So upper chest and neck movement is the primary breathing that I see with a lot of my ladies. So and my men actually. So a lot of them just breathe with their upper chest. And this means they develop these amazing scalene muscles. So they have these really strong neck muscles that they use daily, all the time they're breathing. This also means, however, that when they're breathing, they're bypassing using their entire breath canister or their entire body for breathing. We actually use our whole body, but we're going to focus just on the canister today and a bit of our feet. But so what ought to be happening is instead of just breathing into this upper rib cage here, we should be trying to breathe with our diaphragm. Now our diaphragm is a massive, massive muscle that's huge. It goes, if I would get you to put your hands where your xiphoid process is, so your solar plexus here, okay? And then if I get you to march your fingers up maybe about an inch up further to kind of between your breasts here. So this is kind of the top of your diaphragm here. And then if I get you to bring your hands to where your ribs are and just walk your hands all the way around the costal region, all the way around, so down towards your 12th rib, round the way to the back and into the back. Everybody's slightly different because our rib cage is slightly different sizes. So this is the bottom of your diaphragm. So this whole bit should be descending about 10 centimeters it is for every breath. So it moves a huge amount. I've just lost my ball. So when we are using just our upper chest to breathe, we are not using our diaphragm effectively. And if we're not using our diaphragm effectively, we're also not going to be using our pelvic floor effectively. So we're going to talk about that in a bit more detail. But the majority of people do breathe there, and that creates tension in their necks. They have headaches, they have tense jaws, sometimes they can have eye strain as well. All of this can come just from this upper chest breathing. The other one that I see not so often is paradoxical breathing. So for this one, I would like you just to try it. It's a bizarre breathing pattern. So as you inhale, you're going to pull your belly button in. And as you exhale, you're going to kind of let it go to neutral. So inhale, pulling your belly button in. Exhale, kind of let it go to neutral. Inhale in, exhale neutral. So the transverse abdominis never extends. I find this a lot in women who were told as children or were worried about their weight as teenagers, who have spent their whole lives kind of sucking in their bellies. And this is one of the hardest ones to knock on the head because it's become so ingrained in them. So paradoxical breathing, when I come across it, I'm like, oh no, it's a paradoxical breather. So, but I've got tricks these days. So it's the abdomen, when in paradoxical breathing, it says pushed outwards here, but it's never actually pushed properly outwards. It just comes to a kind of, neutral. And the other one, belly breathing. So we're going to talk about this a wee bit. Belly breathing is when the ribs are essentially bypassed and the lungs push down into the diaphragm and the pressure is pressed out into the linea alba. Now, you're all movement specialists. I'm going to stop the share for a moment. Which one of your muscles in your abdominals are designed to just push out in front? Transverse abdominis goes all the way around. So the transverse abdominis is designed to open like a corset all the way around. So it's designed to open to the front, the sides, and to the back in a uniform way, following the pattern of the thing it attaches to, the rib cage. So if we're bypassing the rib cage because we're breathing down into our belly, then what we're doing is we're pushing all the pressure from the breath out towards the front wall. And this is a big thing for women who have diastasis and things. So this can create a real issue for diastasis, but it can also create a real issue because the pressure has to go somewhere. So if the abdominal wall is quite good and quite good neck, then the pressure will push down into the pelvic floor or push out into weak back muscles. So we're creating an imbalance in how we manage the pressure in our body. We want to be able to use the whole abdominal area like a corset in order for us to be able to manage the pressure better. So I know that in lots of yoga, they teach about belly breathing and how it's nice and calming and everything. But if you go back to actual description of where belly breathing should be, if you take your fingers and you put them just above your belly button, 3 fingers above your belly button, and then think 3 fingers in from where your belly button is. This is a description of belly breathing, by the way. So now imagine where that is. If you think about 3 fingers inside your body, so that's the top of your approximately the top of your belly. So you're going 3 fingers up from your abdominals and then 3 fingers in. So imagine that in the center of you. So think where 3 fingers would go to. Now, put one hand on one of your rib cage, one part of your rib cage. And now I'd like you to inhale and I'd like you to expand your rib cage towards the side. And thinking now that the bottom line of your diaphragm, the bottom line's here, top's here. So it's going to descend, it's 10 centimeters down. So take a nice deep breath in. And think where that diaphragm's descending towards. I mean, the diaphragm doesn't just descend down, it's got different striations. I'm making it really basic. But what's happening is as we widen the rib cage, as we inhale, the diaphragm then does this. It flattens, the central tendon flattens, and the muscles stretch out. And it pushes down towards the organs and pushes down into the top of the belly of your tummy. So if you are inhaling and widening your rib cage to the sides, then widening it all the way around, then you're effectively doing a proper belly breath, but without pushing your abdominals out to the front. Also, you'll notice that if you take a nice deep breath out towards the sides, so if you hold your rib cage, so you're really feeling it. And I mean, your rib cage is amazingly mobile, by the way, and most people's are really stuck. There's like 9 joints in each rib and they're all flexible joints. So when you hold your rib cage and you take and you want to hold it so you can kind of feel the abdominals a bit here at the front too and a bit at the side. So the lowest part of the kind of costal region here. You're going to inhale and I'd like you to feel what happens. If you inhale and laterally move your rib cage to the sides, can you feel how your abdominals widen to the front and also to the side and also to the back? And then if you exhale and close your rib cage, can you feel how they contract? So now we're using our belly, we're using our abdominals, but we're also using some of our back muscles. We're using our rib cage, and we are actually giving our lungs space to inflate, and we're taking the pressure of our body. I'm going to explain this now, right now, what's going to happen with our pressure. So if we imagine that this is a canister in a really simple way, from the pelvic floor to here is like a breath canister. As we inhale, the lung pressure decreases, but the rest of the pressure in the body increases. So we're increasing intra-abdominal pressure. So in order to manage that pressure well, what we want to do is we want to be able to dissipate it around the largest volume we possibly can. So we're going to manage the pressure by giving it loads of surface area. So if we inhale and widen the ribs, we're giving that pressure loads of surface area. So we're managing the pressure. So the pressure is going kind of everywhere instead of just pushing out through your belly, down to your pelvic floor, out through the back, or just being contained up here in the upper chest. Okay, is that clear to everybody? Yeah, so what we're going to be doing is managing pressure through our breathing. But by widening our ribcage to the sides, we're also activating our transverse and our obliques. Our transverse muscle attaches via pleura to the bottom of our ribcage and also to the top of our pelvis all the way around. So when we inhale and widen our ribcage, we're also widening that transverse like a big corset opening. And then as we exhale and close our ribcage, that corset closes. So we're starting to tie in the movement of the ribcage with whatever movement we're going to be doing in our pelvis as well, which is really super important. If we're just breathing up here all the time, we're not going to be making that connection between the two. Okay, the other ones that work. Yes, Suzanne?
Did you say that when you breathe in, because you're creating, with wide breath, creating much larger surface area, spreading pressure? Is that, if I got that right, yeah? But did you say there was less pressure in the lung?
Yeah, so as you inhale, it goes the other way around for the lungs. So the lungs, because you've got to be ready for your so as you exhale, you're increasing it's the other way around. Oh, I always get this mixed up. This is the one that really screws with my head, Suzanne, because the pressure goes in 2 different directions. So we have a negative pressure in our lungs just before we inhale. So yeah, no, negative pressure on the exhale. Yeah. So yeah, negative on the exhale, because then so it's the same way round. That always mix these two up, man. It's, yeah. Thanks for picking me up. It's one that's really always screwed in my head, that I can think about where everything else works, but for some reason the negative and positive pressure of the lungs are one that gets me every time. So yes, so it's working the same way, which is great. That's even better. Now it might stick in my brain. The other muscles, of course, are the obliques that come down like this. So your obliques attach into your ribs. So as you inhale and widen your rib cage, your obliques are also starting to engage. And as you exhale and close your rib cage, they're contracting. So they're extending and contracting. Now, the best thing about this for the pelvic floor is that these obliques come all the way down towards the pubic symphysis, and then they've got a connective tissue connection that goes between them and the adductors here. So the obliques actually are also a pelvic floor muscle, you know, not in so much that they're right through the middle, but they're a support for the pelvis, just as the transverse is when it moves as well. Just as the psoas, so the other muscle is the psoas muscle, and the psoas muscle comes from where your diaphragm is, and it kind of knits in. It's got crura that kind of knit in with each other. It's like, it looks like really nice knitting, and it comes down. Your psoas comes down your back, comes into your pelvis, and then connects and becomes part of your pelvic floor. It connects with another muscle called the iliacus, and then it comes all the way into the front and into your femur. So every time we inhale and exhale, using our rib cage, as we inhale and widen our rib cage, our diaphragm descends and it allows that psoas muscle to release. Then as we exhale and close our rib cage, the diaphragm comes back up and the psoas also does. So we start to get this beautiful movement within the pelvic floor as well. I'm going to talk more about this in a bit. So, safe to say that if we're using our rib cage to breathe with, then we're going to have a lot of mobilization of muscles that cross through our pelvic floor and also up through to our shoulders and our necks as well, in a good positive way, rather than creating too much pressure and tension. Any questions about all of that little journey? Okay, right, back to the slides. Keep me focused, eh? Okay, so breathing patterns. So there's a little bit more for you to look back on and read, so you can go, what was she going on about chest breathing? So there's a little bit more description for you there on that, and also on belly breathing. And here is a lovely picture of the descent of a diaphragm. This diaphragm in this picture is actually not very true to form. Your diaphragm is actually much higher at the anterior side than it is at the posterior side, but it gives you an idea about the movement in the diaphragm and how far it comes down and how far it goes up. So there's a lot of movement goes on in the diaphragm when we're breathing, as long as we're also widening and using our thoracic capacity. Okay, we've got a little bit of information about the fascia now because it's important. So in a really basic sense, fascia is a thin layer of connective tissue. That's the way we see it, that envelops and supports various structures in the body, including organs, blood vessels, bones, nerve fibers, and muscles. Nowadays, there's a lot of discussion about how they're all fascia, and we'll go into that in more detail either in tomorrow's or if you come to do the fascia course. This tissue serves not only as a structural framework, but also possesses nerves, making it highly sensitive, almost comparable to the sensitivity of skin. When under stress, fascia has a tendency to tighten up. And so that means if you think about the pelvic floor, coming out of this for a minute, what am I doing? Out of this for a minute. I have a pelvis coming in the post. I've spent 12 years saying this, but I actually do now. I've had 12 years of going, I need a pelvis. I'm going to show you something about the pelvic floor. I'm going to need another bowl. Hold on. Okay, because I had a lady say to me that her doctor had said because she'd had her uterus removed that she had more potential of everything falling out, which was just a terrible, terrible thing to say to somebody. I was absolutely appalled. So if we imagine we've got our organs and we've got your Levator ani muscle is a series of muscles that go from your coccyx to your pubic symphysis, from your coccyx to your sit bones, and from your sit bones to your pubic symphysis. And they all merge together to create your levator ani. That's the muscle at the bottom. Your organs are actually held in place by a series of ligaments and fascia. So if we have our bladder is at our front wall, just above our pubic symphysis here. Our uterus is above that, and then we've got our rectum at the back. And this whole bundle is enveloped in loads of fascia that supports it. So it's massive fascia connections all the way through our pelvis. That one of the main components of our pelvic floor is fascia. Different types of fascia, but fascia. So if we've got clients who have been maintaining upper chest breathing, they've not been getting the engagement that they can get through the muscles between the diaphragm and the pelvic floor. So they've not been getting the pulse that we can get through the pelvic floor. So we should be in minute detail mobilizing the pelvic floor every time we breathe. But for upper chest breathers, that's just not happened for them at all. And for people who are so terrified that their pelvic floor is going to fall out, they tend to start gripping and tucking their tailbone under, or gripping their upper ribs and pulling trying to pull their bladder up. And this makes them hold their pelvis really, really tight and still. Fascia needs more than anything else. It needs to be mobilized. It needs to be moved. It needs to be engaged. It needs to be twisted. It needs to be, and our pelvis, we're going to do an exercise for it in a moment, which is actually nicked from Franklin. Our pelvis it needs to be moved in all sorts of different directions in order for it to be functional. But women get so scared of moving that they just stop moving altogether. You know, a lot of my women have stopped all their activities that they ever did before. And this in turn makes the fascia drier and drier and drier, and makes them less likely to move, and then can create pain. And then it just becomes this thing where it just gets worse and worse and worse. And so getting them to mobilize is one of the most important things. And that's what our breath work, when we do it, starts for them. The breath work starts the mobilization. And that's the most important thing that we can do for them. Is to get them moving their pelvises again. So I'm going to pop back over to our share. Okay, so yes, when under stress or or just being held tight, fascia has the tendency to tighten up, which is what happens with women's pelvic floors. Fascia is a complex fibrous connective tissue. It's a connection. We have collagen and elastin in there. They both play a very crucial role. Fascia plays a crucial role in the body's functions with its diverse components. Maintaining the suppleness of fascia requires varied movements. And while static stretching that we do initially in hypopressives addresses some aspects, it falls short of addressing the entirety. Fascial stretching involving multidirectional stretches untangles the intricate web of connective tissue, promoting balance. When disrupted or misused, fascial tissue may thicken, harden, or become blocked, emphasizing the importance of proper movement. Unlike muscles, fascia doesn't respond well to force. Instead, and I'm doing an amazing course just now with this guy, and he described fascia in the best way that I've ever heard it. Because my women always say, why do we have to do 10 minutes a day, Abby? Why do you think that? Could I just do 1 hour a week? And he described it, fascia, like wax. So you need to warm the wax for it to start to move. And you don't want to make it totally liquid, because then it's going to go all over the place. You want to gently encourage it to move and to keep moving. And so I describe their pelvic floors now like slow moving wax. So we want it to slowly move and slowly connect and slowly untangle back to where we want it to be as functional. So engaging in multidisciplinary movements and stretching fascial tissue can effectively alleviate tension, stiffness, and pain, not just in the pelvic floor, but throughout the body. We're going to do something called visceral traction in a minute. We're going to do some practical work really soon. So the use of active stretching of the fascia and muscle chains combined with the tensioning and compression of the torso during the breath phase creates a visceral traction, which is then combined with the apnea breath and is creating a vacuum breath. There is going to be, when you do this, girls, there's going to be no active sucking in or pulling up, no Kegel type voluntary movement. The engagement is going to come from slow, mindful, active lengthening and a slow opening of the ribs, which is called a false inhalation. which is going to be held for as long as comfortable for you guys. And then we add postures that help you to move the fascia as well. Now I'm going to come off the share. I think I'm just going to check what's next because I always forget what's next. Oh, we're going to see one. Let's see one. So this is a really visual picture. So just be prepared. So we're going to see hypopressives working. We're going to see, first of all, a sit-up done poorly. A sit-up done well can do what it needs to do, but most people don't do them properly, so it creates too much pressure down the way. So we're going to see a sit-up first, and then we are going to see a prolapse being drawn up by hypopressives. And then I'm going to describe hypopressives to you, and then we're going to take a short break, and then we're going to come back and do practical. Okay, so this is the lady doing sit-ups. This is her pelvic floor. It's graphic, aye. So we can see how the pressure of the sit-up is actually creating too much pressure down to her pelvic floor and is pushing down into her organs. Okay, next one is probably more graphic. So this is the apnea. This is a prolapse. This is a bladder prolapse, and this is during an apnea. So we're going to see an apnea of this.
Tira, fuerte, más, aguanta todo lo que puedas, cuando no puedas más, coges aire y relájate. Muy bien. Ahora quiero que me hagas una abdominal normal o algún ejercicio de pilates, así que puedes hacer tumbada.
Now I'll skip forward so you don't have to keep looking at that for just now. So the prolapse came back down again after she started breathing again. But the more that you do the apnea breath and the more that you do the functional breathing that we do, the more that prolapse is held up, because the more the ligaments are, the more the muscle tone improves. The better the muscle tone is, the more supported the ligaments are. The more supported the ligaments are, the quicker the ligaments can remodel. And ligaments can remodel, they just take a really long time. So depending on how stretched the ligaments have become, or how pulled out of place the ligaments have become, it will depend on how long it takes for your individual ladies to recover. Some of my ladies actually haven't had ligament issues. What they've had is their muscles are just really knackered because of the way that they've been done. And so once we start to improve muscle tone, they're like, yay, I'm suddenly cured. Whereas other women will take longer, depending on what has happened to their individual bodies. So over time, so when we're looking at in recovery, we're looking at 3 to 6 months before people start noticing a really, a daily noticing of difference. But they should, like when you go to the gym and you do stuff, you'll only notice, your biceps getting bigger between 3 and 6 months. You'll notice changes in that time period. And it's the same with our pelvic floor. So for majority of women, it's not an overnight, silver bullet. It's about consistent, slow, deliberate practice. And that's what gets them the prize at the end, because we're slowly training our bodies. So we are going to have, we've got a couple of minutes. That's great, because I've got a couple more things to do. So those videos are the best way to show, but I'm going to explain what actually happened when we come back after the break too. So I just want to do a little bit on pelvic organs, just so you know them, what they look like. And this is probably better than me and my balls and my, my stuff. In this image, we can see how connected the organs are to the fascia and each other. And how if we have dysfunction or removal of any of them, there would be an imbalance. Yes, there would be an imbalance. So for example, my lady who had her uterus taken out, yes, there would be an imbalance, and she would need training and proper rehab for the rest of the body to start taking on the space where the space is, and start correcting where the space is where the uterus used to be. It doesn't mean that everything's going to fall out though, as long as she's given proper rehab. And honestly, the horror stories some of my women are told before they find me, it's no wonder they're in crisis, because their mental state really affects their pelvic floor. And we'll talk about it too. So male and female, hypopressives are not solely for women. Hypopressives are also beneficial to men who also have connective tissue disorders and can have bladder and anal incontinence. For men, bladder and erectile dysfunction can be compromised due to prostate removal, which for many is an elective surgery to avoid cancer. And they're not always told that they're going to have erectile dysfunction afterwards. They're usually told they'll have urinary incontinence, but they're not always told about the erectile dysfunction. So the men that I've met have been absolutely delighted when they've got back their function of their willies after they've done it. So men also suffer from pudendal neuralgia, not from childbirth, but from activities like cycling. And this can cause a pinching of the nerve, of the pudendal nerve, or an entrapment of the pudendal nerve, usually in the Alcock's canal, which is part of the pelvis. And doing hypopressives can help to release this. But you can see here that our pelvic floors are not that different if you look at them. It's just that we've got a few more pouches and a few more orifices, and that's it. That's the only real difference. You know, our musculature is largely similar. Okay. And as I've been discussing, the pelvic floor is not a solo operator. We are very wrong to treat the pelvic floor as a separate entity because it most certainly isn't. The pelvic floor has many hats. It's for breath, it's for sex, it's for stability, it's for support for internal organs, it's a sphincter, it's also a sump pump, circulating lymphatic fluid. It's got so many roles, and we have to work it in all of those roles, and as part of all of those teams of muscles, which is why the poses that we use connect different muscle chains together and activate them when we do them. Just a quick look at pelvic organ prolapse, and then we're breaking. So pelvic organ prolapses. They're not all here. So there's not a rectal prolapse here. And there's also not a vaginal vault prolapse here. But you can see the normal anatomy. A cystocele is a bladder prolapse. So it's where the bladder starts to push into the vaginal wall, which is what we saw in the video. A rectocele is where the rectum pushes into the vaginal wall. An enterocele is probably the most unusual one and tends to only happen if a woman has had a hysterectomy. But that's when the small intestine comes out through the vagina. But it's really pretty rare. And then we have a uterine prolapse, which is where the uterus comes straight through the vaginal canal. And then what's not shown here is things like a vaginal vault prolapse. So that's when the vaginal muscle just it atrophies or becomes too wide and balloon-like. So the more we do hypopressives, the more the vaginal wall starts to work as a muscle again, because it is a muscle, and the better that one becomes. And the rectal prolapse is where the mucosa comes out through the anus. Any questions about any of this that we've covered so far before we have a little break? I'll stop the share. We're going to come back and do practical. Yes, Suzanne.
I found those videos fascinating last time and really fascinating this time. I'd really like to be able to look at them again. Where could I find them, or is it not possible?
I've got them, so I can share them with you.
Thank you.
I'll do that. I will share them with you. I have them somewhere in my computer, Suzanne. I will find them, and I will share them with you. So I'll just put a wee note to myself about videos.
You'll be able to share that with all of us?
Yeah, I'll just put it on. I send you out like a newsletter thing, so it has all the information on it. So I'll pop that in, and I'll pop the research about Huntington's in there as well, because people wanted that last time. Yeah.
It's so visual, and I think it really helps when people want to do all these crunches all the time. It just what happens.
The thing is that which I always say, Suzanne, is there's no bad exercise. So doing a sit-up or doing a crunch, when done properly, it can be a very beneficial exercise. But when you're just throwing yourself into it, then and you don't know what you're doing and what you're activating, then it's not. I'm always very, very keen to say there's no such thing as any bad exercise, just poorly executed. The army used to do massive sit-up competitions, and they stopped doing them because they had so many herniated discs that they ceased doing that. Yeah, they ceased doing that as an exercise thing.
See, that's so good to know, to tell people. That's fantastic. Thank you.
Yeah, Yeah, yeah. I mean, it's why are you doing sit-ups? And especially women who have diastasis. I did this because I was a total gym bunny. And I used to do like 100 sit-ups a day before babies, and I was fine because, well, maybe I wasn't fine. Maybe that was the start of the issues. But afterwards, I had a diastasis. And because I was doing sit-ups and not doing them well, because I didn't have the compliance, the abdominal compliance there, and my diaphragm, my transverse wasn't kicking in when it should have done. And what was happening is that I just actually started creating more and more and more and more of a diastasis. So I have a lot of women who come to me who say, oh, I've been doing loads and loads of sit-ups and my waist is getting wider. It's not getting narrower. And I'm like, hey, go figure. And then I explain that to them, and we look at other things they can do alongside hypopressives instead. Yeah. Okay, guys. So we're going to have a short break. We're going to have a 10-minute break, 10, 15. Let's have 15 because we're going to come back and nail loads of stuff. So I want to give you time to get water and also a pee. So we're going to come back at 10:02. Is that right? Yeah, 10:02. Okay. Right. I will see you all at 10:02. Come back with questions. Yeah. Okay. See you in a minute. Bye. Pause the recording. Hi guys, welcome back. So we are going to do some practical now. Hi. My kids are actually up, which is just like, hallelujah. How's that happen? I totally expect them still to be in bed by the time we finish. So I might have to make them lunch at lunchtime. Who knew? Okay, so let's go for it. We are going to start on the floor. Find a mat. And I'm going to change my mic so you can hear me clearly. And we're going to come over and have a little chat about breath. Okay, I'm just going to mute everybody so you can unmute yourselves when you need to.
It'll be all right.
I just need. Good. Do please unmute yourselves if you want to ask a question. I'm just going to put this other mic on so that you can hear me in the other rest of the room. And we'll get forward and about it. Okay, so the first thing I would like us to do is we are going to have a look at ribcage expansion, and we're going to do this lying down so you can feel the back of your body on the floor too. So we're going to start by coming to lying down on our backs with your knees bent and your feet flat on the floor. And the reason we're releasing our knees like this again is for your psoas, your hip flexor. And also it stops people from arching their backs when they reach their legs out, again, hip flexor. So lying on your back. First of all, we're going to just line up our domes. And I'm not somebody who likes us to hold things really static all the time because our body's not like that. For this one, what we're going to do this exercise, and then we're going to actually then we're going to do a release exercise, and then we're going to come back and do it again. So our feet are flat on the floor. I'd like you to find your pelvis just relaxed on the floor, just land where you've landed. I'd like the weight in your feet to be the same as the weight in your pelvis. Good. And now just like this, I'm going to go through the assessment that I do with my clients when I first meet them with you guys just now. So the first thing I get people to do is I get them to land, and I get them just think about their pelvis being the same weight as their feet on the floor. The next thing I do is I ask my clients to just become aware of where their rib cage is in relation to the floor. So I want to know whether their rib cage is off the floor or whether their rib cage is on the floor to start with. So that's the first thing I'm asking. And this is to determine whether they're people who habitually thrust their rib cage forwards, or whether perhaps they've got more of a kyphotic spine, so whether they're more lordotic or kyphotic. So figure out where your one is just now, and I don't want you to do anything to it, I just want you to keep it where it is just now. Then we're going to find a reasonably neutral pelvis. So you guys all know how to find a neutral pelvis, or, pelvis neutral is so different for different people. We're going to do a nice exercise standing that's from Franklin actually, to just feel that kind of neutral. But for now, a nice way to do it on the floor is to tilt through our pelvis, so arching our back off the floor, then tucking our pelvis under, bringing our lower back towards the floor. So rocking through our pelvis, forwards and backwards. And we're just sensing where the center is between the forwards and backwards movement of the pelvis. And for everybody, this will be slightly different. So you're just going to find where your center is. Quite often when I do this in a longer class, I'll do right and left as well. So we go side to side as well, just to make sure that we're thinking about the sides of our pelvis too. Then once you find your neutral pelvis, I'd like you to see whether your rib cage is on the floor or off the floor still. So if, for example, my clients have come to me and they start with their rib cage off the floor, and then we find a neutral pelvis and their rib cage is still off the floor, then that tells me that they're somebody who flares their rib cage forwards, and it's not got very much to do with what's going on with their pelvis. Their pelvis is fine where it is. If they've had their ribcage off the floor and then we find a neutral pelvis and the ribcage is now on the floor, that tells me there's somebody who tilts their pelvis forward a lot, so anteriorly tilts, rather than thrusting their ribcage forwards. So it gives me a couple of clues about what's going on with the orientation of their ribs and the orientation of their back. If they had their ribcage on the floor and then when we got their pelvis into neutral, their ribcage is now off the floor or lighter on the floor, it tells me that possibly they've got a bit of posterior tilts going on. So again, I'll look at this when they come to standing. So this is just to give me some little indication about what's going on with their bodies. So I'd like you to find your neutral, which we've just done, and I'd like you to try and have your rib cage as close to the floor as possible, keeping the lower lumbar spine slightly off the floor or lighter on the floor. So we're following the natural curves of the spine. The neck is off the floor and the back of your head. So if you take your hands to where your neck is and slide your hands up until you feel the occipital bone, the bony protrusion, and place that on the floor, so you're gazing straight up towards the ceiling, then we've got a really lovely like shape for your spine. Now the next question I ask people to do, which is one I asked you at the beginning, is to just breathe, and I observe their breathing and I get them to become aware of it. So just take some nice slow breaths in, inhaling and exhaling. Now for now, guys, I'd like you all to exhale through a relaxed jaw. And the reason I'm asking you to exhale through a relaxed jaw is because I want you to be able to keep your jaw relaxed while we're doing the exercises. If we hold tension in our jaw, we hold tension in our pelvic floor. And initially, when I first meet people, I get them all to do it like this. But then once they can keep a relaxed jaw, then they're free to inhale and exhale through their nose. But to start with, to make sure there's no tension being held in the jaw, I get them to relax their jaw on the exhale. So it's just, we're going to exhale as if we're misting a mirror or misting the window on the back of a car, so you can draw something naughty in it. So it's that kind of feeling of playfulness. So we've got that. So the next thing is head, actually. So if when you're pulling your hands up the back of your head and putting the occipital bone on the floor, you find it really difficult and your eyes are actually looking over the top of your head, that's when we need a little block underneath our head or a little pillow. So then from here, I'd like you to bring your hands, next thing I'm going to get you to do is what's called a cough test. So what we're testing here is we're testing how compliant or how well your abdominal muscles absorb tension or stress. So what we're going to do is put your hands on your abdominals, just lightly, and then I'm going to get you to cough. And I'd like you to feel what your abdominal muscles do. So you're going to cough. And you're going to feel with your what your abdominal muscles do. Do your abdominal muscles stay where they are? Do your abdominals move up and then come back down really quickly? Do your abdominal muscles come up, kind of move around and come down really slowly? So if they do the last one, the latter, where they came up and they come down really, really slowly, that tells me that your transverse muscle is not kicking in very quickly. So it's not working as well to absorb the tension or the force of the cough. So the force absorption is not great there. If it goes up and comes down, it means it is kicking in, but it's a little bit slow. If your abdominals stay where they are, then it's working pretty well. If your abdominals go in, it shows us that your body's really working really well for force absorption. And so when my teenager coughs, his tummy goes in because his body's, not been screwed around by the world yet. So his is working really, really well. So this is called the cough test. And this is what I test my clients in this when I first meet them, and then we retest in 6 weeks just to see how this has changed. And this makes a massive change quite quickly. The next one we do is a cough test again, but this time I'm going to get you to take your hand and place it between your legs on your vulva. And then you're going to cough, and you're going to see what your vulva does. Does your vulva Stay where it is. Does your vulva go up? Does your vulva stay where it is? Does your vulva come out and then go back up very quickly? Does it come out and feels like it just falls out into your hands? Which one does it do? So again, this is scored 3 to 0, 0 being if your body absorbs the pressure, a 3 being if it really, really is not very compliant and not working very well at the moment. And again, this is another one we can retest. So this is telling us whether our pelvic floor is connecting in with our diaphragm when we cough and is absorbing the force. Okay, coughing, throwing up, coughing, throwing up, and double unders are 3 of the most intense things you can do for your pressure in your intra-abdominals. So, next thing. Any questions about those so far?
What you can't quite tell.
Which one?
On the cough and the diaphragm releases or pulls up.
So you're actually just feeling what happens with the tissues. So if you cough, which the tummy one or the one in your vulva?
Vulva.
Yeah.
Vulva. So if you've got your hand here and you cough and you can't feel anything happening, then that's a good sign.
Okay. Fine.
Yeah. Overall, that's a great sign. So even if it feels like if you can't feel whether it goes up or just stays where it is, that's fine. It means that your pelvic floor is basically functional at the moment. Jenny.
Can I ask what a double under is? You said
Double
that.
under is something they do in CrossFit, where and I've got loads of CrossFitters where it's skipping, and what you do is you take the skipping rope under twice, and it's generally the point where everybody pees themselves.
Okay.
And it's not actually the exercise; it's because they breath hold when they're doing it, and so they create even more force and tension in their bodies because they're not breathing. So that tends to be it. So that's what a double under is. There's a whole list of different things that create the most tension in your body, but those 3 are the biggest ones.
So if you pee yourself when you cough, would you normally feel that drop down? You'd feel it?
Yeah, you'd normally feel it, move out.
Right.
Even a little bit. What it's telling you? What it's telling you is when we cough, our body has to do some things. So it has to be able to absorb, like if we were to put a bomb in a fridge and shut the door, it's like, and then when the bomb went off, the fridge or the freezer would hold, it's one of the, if that ever happened to you, you'd put it in a freezer because it would absorb the pressure of the bomb. So when we cough, our body wants to absorb the pressure when it happens. So it does force absorption. And what happens with the pelvic floor is the pelvic floor has to lengthen and then contract again pretty quickly. So it has this timing thing that it has to do. And if we've got a poor pelvic floor function, or especially eccentrically loading, when we cough, it just gives way. And we don't want it to just give way. We want it to kind of work in an extension and then contraction quite quickly. But what tends to happen with people is because they've got so much tension in their pelvic floor that when they cough and their body's required to lengthen, it doesn't have the strength in that to eccentrically load, and that's when you feel that give way. And that's when things like incontinence happens with jumping and coughing and sneezing and laughing. What's worse than not being able to laugh, eh? Evie. Oh, not Evie.
Sorry, I will change it.
That's all right.
When you say giving way, that people are feeling, you can feel that bulge, you can feel it pushing into your hands. That's what they would describe to you. Yeah. And then what are you grading at? So not being, they can't feel any change at all.
Not being
no bulge.
So not would be it going back up inside. So not would be the feeling of absorption, really absorbing and stopping the feeling of Whereas 0 is not moving, 1 is it going out and coming, 1 is it 0 is it going up, 1 is it not moving, 2 is it going in and out quickly, 3 is it coming out and taking ages to go back in.
Right.
So I was a 3 for both of those when I first started. And generally, if there are 3 and I'm doing this online with them and they've marked a 3 for the cough test with the abdominals, then I will immediately go and test them for diastasis and check what's going on with their abdominals, because quite often that will mean that they've got some sort of diastasis happening. And then that will lead to the question where I ask them if they've got, stuff protruding, if they're sit up, and they go, yeah, and I go, you filled in my medical form. We can't do the apnea if you have a hernia. But people don't always tell you the truth till you're actually doing stuff with them. Yeah. Sorry, and we'll go through the medical contraindications there on the sheet that you've got as well, so don't worry about those. Okay, so the next thing we're going to come to do is we're going to come and breathe. And we're just going to breathe using lying on the floor again, because when we lie on the floor, our diaphragm is not working so hard as a postural muscle. When we're lying on the floor, we can focus on the diaphragm as a breathing muscle. So we're thinking it more when it's tonic. So when it's tonic, it's doing like little flutters through the muscles, rather than when it's standing and having to do rotations and moving, it's more phasic, which means it's working much harder. So we're going to lie down and do this whole bits of the breathing to start with, so we're just using it as a tonic muscle. Okay, so we're going to come back down. You're going to find your neutral pelvis, ribcage like heavy on the floor, but same heaviness as the pelvis, and the back of your head on the floor too. Perfect. Then I'd like you to take your hands and place them around your ribs towards the lower portion of the ribs. Good. And now I'd like you to focus on moving. We're going to build the breath slowly. So the first thing I'd like you to focus on is as you inhale, I'd like you to widen your ribcage laterally to the sides as much as you can into your hands. And as you exhale, you're just going to use the exhale to slow the descent of the ribcage back to its resting place. So we're not trying to force out an exhale, we're doing that gentle kind of exhale. So we're not trying to exhale all the air out, we're just going to the end of your natural exhale. And we're using the exhale, we want the exhale to be as long as possible to slow the closing of the ribs. Good. So keep doing that a few more times while I explain. As we inhale slowly and widening our ribcage to the sides, we're giving ourselves space for our lungs to inflate, and we're also creating more space to dissipate the pressure around. As we slowly exhale, we're allowing the CO2 time in your body to do its dance with your hemoglobin to help release ATP energy cells, and we're also giving your CO2 in your body a chance to work with your respiratory system to cleanse it. So the CO2 leaving your body is one of the biggest cleansers of your respiratory system. So we want to take as long as possible on our exhale. It's also one of the things that helps to calm your nervous system down. So especially for women who are worried and anxious about their pelvic floors, it is a great way for them to get better balance. So slow inhale and try and exhale for almost twice the amount of time as you inhale for. And laterally move to the sides. Okay, so now we've done a few with just lateral movement. Now I would like you also to think about breathing so you can feel your thumbs towards the back of your rib cage. As you inhale, I'd like you to feel that stretching at the back of the rib cage as well. So the rib cage at the back kind of fans and stretches, so it'll stretch slightly back into your thumbs as you inhale. So we're inhaling and we're widening to the sides and we're widening to the back. So just feeling that movement of the rib cage to the back. A lot of people have no movement in the back of the thoracic cage. So we want to introduce that movement back there because our lungs are mainly back there. So inhaling through your nose, widening to the sides and then to the back. And then as you exhale, just allowing your rib cage to close nice and slowly, using the exhale as a break. So let's do 3 of those. Inhaling slowly through your nose. And exhaling slowly through a relaxed jaw. And one more. Good, nice.
Oh wow, really?
I'll mute everybody. Nice and slow. Okay, so that's part 2 of our breathing. So we're going to bring in part 3 now. Now for a lot of people, a lot of posture patterns with women that I see, there's 2 posture patterns they hold. So relax for a moment and I'll jump up and be a bit insane. So the 2 posture patterns that I see the most with women are, there's a combination always, but one of them is that they start to tuck their tailbone under to grip the pelvic floor. So you see these bottoms that just disappear underneath them. And this can start to, when it gets really extreme, it starts to create that kyphotic spine because everything has to kind of follows on suit from it. And this can create issues which we'll release when we come to some of the poses. The breath one though, the big breath one that we're trying to release is the one where they start to grip with their upper ribs. So it's like they almost try to pull their body up from here. So this gets insanely tight in here. So when we're starting the lateral movement, we're starting to create a release there. But we also have to address the fact that their sternum has started to collapse in. So when they do this, their sternum also starts to collapse in here, and we get this real tension and tightening through the fascia in this area here. So the third part of the breath is this. We're going to do it again lying down. I'm going to show you here just momentarily. We're inhaling and widening to the sides first, then into the back a little, and then I'd like you to think about the sternum widening. So it's widening, and it's almost like it's lifting a little bit towards the underside of your chin. So it is not thrusting out to the front. It is opening this way. So you can feel it when you breathe. So if you put your hand just wherever you are just now and take a breath in, and I'd like you to feel that opening between the second and first rib. So kind of just underneath your clavicle. And then exhaling. Can you feel that movement there? So now as you inhale, I want you to think about that area, trying to lift just gently up towards the underside of your chin. So like you've got a little hot air balloon attached to it that's just lifting it up gently as you inhale. So there's some slight movement up. And then as you exhale, I'd like you to try and keep it up. So we're never going to drop completely down like this. We're not going to start rocking like this we want to keep this kind of feeling of openness in here.
Can I quickly ask there, if you're not really feeling the sort of expansion and sort of the lifting and the opening, is that because you're probably quite tight there?
Yeah.
Yeah.
Yeah, probably really tight there. So yeah. Focusing on it as at the end of the breath. So if you think about it like almost like a wave, the breathing. So the sides, the back, and then the sternum. And then as you exhale, it's just allowing everything to drift back in. So the action part is the breathing. But yeah, the more you kind of tune into it, Sophia, the more you'll start to feel it. Yeah. Okay, any questions from anybody else just now? I do love a question, by the way, so do share if you have one. So coming back to lying down, because it's easiest to, because of the diaphragm being just a little bit less challenged in this position. So find your neutral pelvis, the ribcage on the floor. As you inhale, I'd like you to make sure the back of your ribcage stays on the floor, even though you can feel that expansion. And as you exhale, I'd like you to keep the ribcage on the floor too. A lot of clients I see as they inhale, they'll lift their ribcage because they flare to the front a lot when they breathe, and predominantly just move towards the front rather than laterally into the sides. So let's do 3 breaths. So we're going to inhale, widening to the sides, behind and into that sternum, just really thinking about the whole ribcage widening. And as you exhale, just allow it to slowly drift back in. Good. I'm going to do another 2 here. Okay, there's another part to this breathing, but we'll introduce that after I've introduced the next bit, because I don't want to give you so much that I confuse you. So we'll come back to that, the last bit, which connects kind of the pelvic floor in with this area. This time, what we're going to do now is we're going to do a lovely thing called a breath reset. So I'd like you, first of all, to think about something, someplace, or someone who brings you joy. So this is me actually starting to talk to my clients' nervous systems as well. And I'd like you to use that thought when you inhale, so the action part of the breath. Now I'd like you also to think about something, someplace, or someone who brings you calm or peace in your life. And you're going to think about that when you exhale. And we're going to do 3 breaths. As you inhale, focusing on ribcage to the sides, behind, and sternum moving as you think about your joyous thing. And as you exhale, you're going to slowly allow them to close back down, thinking about your calm thing. We're going to do 3 of these breaths. At the end of the 3rd one, you're going to close your mouth and nose. You're going to pause. You're going to hold the air out. and you're just going to wait and listen for your body's own natural need to inhale. So you're not gonna Wim Hof it and try and hold all the air out forever and ever and ever. You're going to just listen for your body's own natural breathing impulse. So whenever you're ready, you can have your hands around your rib cage. Relax your eyes. Relax your feet and your toes. Relax your face. Now your 3 breaths. So inhaling in your joy. And just this is in your own time. And just exhaling and allowing the ribcage to slowly drift back into the center as you exhale your calm. And at the end of the 3rd one, you're just going to close your mouth and nose, keeping your jaw nice and gentle, keeping your eyes nice and gentle, and wait in your calm space. Still thinking about your calm space. And just see how long you have in that calm space before you need to breathe. So don't pinch noses or anything, Suzanne, just relax. You're not doing anything special here. There's nothing going on. You're just chilling. Cool. Okay, so you're going to do 3 breaths again. At the end of this 3rd breath, you're just going to pause again, and I'd just like you to count in your head how many seconds you could pause for comfortably before you feel you need to inhale. And then you're going to give me a show of hands. Show me how many you think you've got. Cool. Good, that's good. Good. So let's see those shows of hands once you're done. So don't worry if you're first before everybody else. And show me on your fingers. Cool. 10s, 5s, 8s. Cool. We've got a good breadth of different ones. Brilliant. Okay, cool. 7s, 12s. That was a 12. Okay, cool. Yeah, cool. Yeah. Okay, so this is showing me how tolerant your body is to CO2. The longer you can chill, therefore, the better your body is at managing, at being tolerant to CO2, and the easier breathing probably is for you, and the less you're probably a frantic breather. So the less you can hold the less you can chill there, the less amount of time tells me that you're less tolerant to CO2. And this is something that will improve with time, and this is something again that you can retest. So what we're going to do now is we're going to use that space between breaths. I'm going to explain the thing after we've done it, so we're going to do it first. So we're going to do exactly the same thing. We're going to lie down on our backs, do exactly the same. We're going to do, but there's going to be a little catch. We're going to do our 3 nice slow breaths. At the end of the 3rd one, we're going to pause, close our mouth and nose, and then we're going to stretch our rib cage towards the sides and behind, widening it as if we were taking a breath while holding our air out in our nice, calm, safe space. So we're inhaling, exhaling, inhaling, exhaling, inhaling, exhaling, closing our mouth and nose, pausing, holding the air out, and widening our ribs. Now remember, when I talked about Marcel Fries, I said he had discovered that there was this great synergistic movement or antagonistic movement between the serratus anterior, this muscle here, and the widening of the ribs. So we can use the serratus anterior to widen our ribs. But let's not think about it too much. Let's just try it and see how it feels in your bodies. Again, we're lying down because it's easier for you to do lying down to start with. For most people, not for everybody. So find your neutral, roughly. So it's a nice rough, it's a kind of stacking up, a nice rough stacking up of the pelvis and the ribcage. 3 nice slow breaths. And really keep it nice and calm. Inhale in your joy, exhale out your calm. And at the end of the 3rd one, you're going to pause and slowly widen your ribs. Keep your jaws relaxed. And do it a few times through. Give yourself a chance to just feel what this feels like in your bodies. Don't overthink it. It's just like the $1 million thing to say. Nice. And we always do the 3 breaths because at this stage, because we're building up the residual oxygen in our body again before we come to do our apnea. And remember, when you're doing this apnea breath, you've got the power to breathe whenever you want to, and you have tons of residual oxygen in your body. Good. Now, when you start to feel, if you're doing this and you start to feel that your abdominals are kicking in, just widen your rib cage a little bit more and allow those abdominals to slowly kick in a little bit more. That we don't want to, if you start to feel your abdominals kicking in, we don't want to then think, oh, well, I could suck them in more to help get that feeling, because then we're doing that drawing inwards from the Uddiyana Bandha rather than the activation of your muscle chains from your rib cage and from your diaphragm, which is what we're looking for. So any questions about that before I give you some hacks or some tips?
Yeah, when I held the breath and then expanded my ribs, I noticed I was not a huge strain, but I noticed in my neck and funnily enough on the right side of my hip, there was like a tension. Is that normal?
Yes, so it is, yes. So we've exhaled all our air, and when we've exhaled all our air, as we exhale, our sit bone draws underneath, our coccyx draws underneath our body, and it stretches the paraspinal, so all those muscles stretch out. Then when we widen the rib cage, we're creating more of a stretch, which is why we get more of a stretch through the quadratus lumborum when we're doing this. So you will naturally, your quadratus lumborum comes all the way up here and all the way down there. So you'll be feeling that activating, yeah, and that's totally normal. So if you're feeling that's totally normal, it's interesting that you feel it on one side. Yeah. So that would make me look at imbalances when you're standing. Perhaps there's more tension on one side when you're standing than there is on the other. But again, as we work through poses, that should start to straighten itself out. Yeah.
Thank you.
That's okay. Any other questions? I'm going to give you some hacks, don't worry. So if it didn't happen for you, don't worry. Yeah. Jenny, did you have a question? Nope. Okay. So not everybody gets it first time when we're doing it like that. So there are some other things that I give people to try. So don't worry. It's a really weird thing we're doing with our bodies to start with. It starts to feel really good and really natural. No, it doesn't look natural after a while. So first thing that we're going to do is we're going to go back to lying on our backs. And I'm going to talk you through. We're going to do 3 nice slow breaths. At the end of the third one, you're going to pause, close your mouth and nose, and then I want you to imagine that you're sniffing a flower through a blocked nose. So what it's going to do, that feeling of sniffing a flower, is it going to elicit a movement in your diaphragm and in your serratus. So it's a connection there. So you're not actually sniffing the flower, you're not taking in any air. The best way to think about it is blocked nose. So 3 nice slow breaths. At the end of the third one, you're going to close your mouth and nose, pause for a moment, relax your face, and then think about sniffing a flower with a blocked nose. See how it feels in your body. This one might not work for you. There might be another one that does, but it's good to have all these tricks. So hands back around your rib cage. Three nice slow breaths. Really focusing on the movement of the rib cage, because it's the same movement that you do during an inhale that we're using for your exhale. Your lungs and your rib cage actually work separately from each other while working together. So flower, block, nose. And then a thumbs up to let me know whether you liked it, or a thumbs down, or ooh, I'm not sure, in the middle. Yeah, okay, cool. I've got others, don't worry. So the next one we're going to do is we're going to come away from the visualization for a minute. We're going to come back to it. But this time, after your exhale, when you pause and close your mouth and nose and hold the air out, I'd like you to think about releasing your abdominals, about 25%. So sometimes what happens is when we exhale, our abdominals are so compliant and so strong that they hold the rib cage closed, and when you go to try and open them, there's too much tension there for them to open. So this is another way for us to look at it. So we're going to do 3 breaths again, and at the end of the third one, you're going to close your mouth and nose, hold the air out, release your abdominals a little, so you're not just letting completely go, and then widen your ribs, pressing your ribs out towards the sides and behind, and thinking about that little bit of upper sternal movement too. And once you finish that one, thumbs up, thumbs down, or questions if you got them. And then good, good. Okay. And we're going to go back to visualization. So I want to give you a whole range of things. Hannah, you had a question.
Just linked into that last one, for me, it almost feels like if I relax, then my ribs move out of their own accord. Is that part of the last one you're talking about, or am I doing something amiss there?
No, I mean, if you feel that you're getting that, I also want you to actively stretch, but if you're also getting a little bit of a passive stretch happening, you know, a recoil stretch happening, then that's okay too. The reason I want you more to actively stretch is I really want you to get into that serratus. Whereas if we're just relying on kind of the ribs springing open, we're not so much activating the serratus, which means we're not going to get the activation through the lats and things that we're looking for, and then into the glutes. Yeah.
Right.
But we're going to talk about that one too, because that's the way that another school in the UK teaches it. So I'm going to talk about the passive stretch in a moment as well. Yeah. Okay, so good question. So the next one is back to visualization. So this visualization is a little bit weird, but also good. So when you were kids, or even now, you know, if you get a glass like a champagne, or maybe like a raspberry iced tea or something, there's raspberries in the bottom of it, or strawberry, and you have a straw. When you go to suck, you know, if you try to take the fruit out the bottom of the jar with the straw, you don't suck like a tight suck, you have to do that kind of sucking round the object, the kind of suck. Now, I'd like you to try that with your mouth closed. So you're going to close your mouth and do that action just before you even do the apnea. Just close your mouth and try and do that kind of feeling of sucking like that without taking in any air. Can you feel how it starts to activate your serratus behind you? So not, yeah, good. Not sucking tight, so just thinking about it here. Yeah, good. More like that, Lucy. Good. So then do your 3 breaths, and at the end of the third breath, close your mouth and nose, relax your abdominals if that felt good for you before, and then try that idea of sucking the strawberry out the bottom of the glass. I was just teaching my kids to do this the other day. Because we're wanting that antagonistic movement between the serratus and the costal muscles. Nice. And again, if this one doesn't work for you, that's also okay. There's lots of other ways into this. Good. But you may find that usually with my ladies, one of these works. Carol, that thing at the back on your back, I'm going to release your diaphragm in a minute. I'm going to teach you a fun exercise before lunch for releasing the diaphragm, and hopefully that will sort that one right out. It's good. It makes you feel like a 5-year-old. So I like exercises that make you feel like a 5-year-old. Yep. So nice and slowly. Okay, again, thumbs up, thumbs down, in between, just so I get an overall view of how that felt for people. Once they've done that one. Good. Yeah, okay, yeah, some of them work better than others for everybody. So the next one is one that I teach people If they really are struggling to make the disconnection between inhaling and exhaling, and being able to open their ribs without inhaling. So it's only done to teach this release kind of feeling, rather than something we do all the time. And it's the only time I'm ever going to ask you to do a forced exhalation, like a proper trying to exhale all the air out of your body. And it's to get you to your brain to acknowledge the fact that it can open your ribs can stay open with even while you're breathing. So and vice versa. So it's just as an exercise to activate that. So I'm going to explain it to you. What we're going to do is we're going to inhale and widen our rib cage. Then we're going to keep our rib cage wide as we can while we exhale. Then we're going to inhale into and I'll talk you through it. Inhale into our already open ribs. And then we're going to exhale again, keeping our rib cage open. Then we're going to inhale again, and this time we're going to exhale and really close our ribs. And then we're going to close our mouth and nose, pause, and widen them. And you will get some elastic recoil, which should get your body to realize what it needs to do for the apnea. So this is when almost all else has failed, I bring this one out of the bag, although I have another couple. So lying back on your backs, I'll talk you through it. So hands around your ribs so you can feel what's going on with them. We're going to do our first breath. So we're going to inhale through our nose. Inhale through your nose, and then once you've inhaled, you're going to hold your ribcage open as you exhale. So keep the ribcage open and exhale. Once you've exhaled, you're going to inhale into your already open ribs, trying to keep them wider. And then when you're ready, you're going to exhale, keeping your ribcage open. Then when you're ready, you're going to inhale into your already open ribs. And this time when you're ready to exhale, you're going to exhale all the air out, really closing your ribs. Really think about them closing quickly. Now close your mouth and nose and allow your ribcage to open and widen. So this is teaching your body that it can do it. But this isn't one we want to do all the time, because you would have felt in your body. So just doing that forced exhale on its own, I want you to feel what happens with your body. So lying on the floor, you're going to inhale, and then I want you to feel what's happening in your abdominals as you exhale, if you really force all the air out. If you feel like you can start to get that little bulging or a feeling of pressure down the way, which is why we don't want to force exhale. Whereas if we do a natural exhale, so do another one and naturally exhale, so inhale, and just let the air out, you feel how you don't get that pressure change. Yeah. Okay, so let's try another one for the apnea for folk. So this one is really very thinking about just your rib cage movement. So your rib cage has got a fulcrum point at your solar plexus. This is very basically because it's got lots of other things that happened, and one at the back of your body as well. So as you inhale, I want you to think about your rib cage opening to the sides as if it's two separate bucket handles on either side of your body. So as you inhale, the bucket handles open. As you exhale, they close. Inhale, open. Exhale, close. Inhale, open. Exhale, close. Close your mouth and nose, and then open your bucket handles. So thinking about it, it's a very mechanical thing. Good. I'm going to explain what's actually happening in your body in a minute too with this as well. What is the mechanics of this? Why this helps to lift your pelvic floor. The final one is one I hardly ever use, because we use our arms a lot in hypopressives, because your arms are connected to your back muscles are connected to your glutes are connected to your pelvic floor is connected to your legs, so we kind of need these guys to work and be engaged and active when we're working. But this next one sometimes works for people. So but I don't want you to get wedded to it if it works for you. I want us to find another way. So we're going to do our 3 breaths. At the end of the 3rd breath, you're going to close your mouth and nose, chill out, relax for a moment, and then you're going to hold your nose. And you're going to do that thing like you want to hold your nose and you're going to jump under water And then you're going to allow your ribcage to open. So sometimes it's holding of the nose and almost breathing against the nose, like you're trying to suck in air through your nose, but you're holding the nose so it can't happen. Sometimes this helps engage again. So 3 nice slow breaths. I used to give my women those swimming things to put on their noses, so they just breathe through their mouth, so they could still use their arms, but it's not ideal. And again, it's creating an activation of that serratus, but kind of through a different way. So I'm going to, if you come up to sitting, I'm going to explain what's happening in your bodies when you do this, and then we're going to come back and practice again, because sometimes if you've not quite got it, if you're somebody who really likes to think about the anatomy of things, sometimes knowing about what's going on in your body is what's going to help. So I'll stand up actually, so you can see my whole body. If we think about this whole area as a pressure chamber, which is very basic, when we inhale and exhale, the pressure is constantly changing. When we come to close our mouth and nose, the pressure in our canister is going to stay the same. It's not going to change because we're not inhaling and exhaling. Now, if we widen our ribcage, when we widen our ribcage, what's happening is as we widen our ribcage, the central tendon of the diaphragm is drawing down. The epiglottis here actually draws down a bit too, which is why sometimes you might feel you get a little bit of dryness in your throat or a feeling like a suction here. That's the epiglottis drawing down. So what's happening is as we widen our ribcage, we're creating more volume here, which means we're increasing the pressure here too. By increasing the pressure here, we're remembering we're in a closed pressure system, which means if we've increased the pressure here, our body has to decrease the pressure somewhere else in the system. So what our fascia does, our clever fascia, is our parietal fascia that goes all the way around from our diaphragm, all the way around, round above the top of our pelvic organs. What it does is it draws everything up towards the diaphragm, and it decreases the volume here and decreases the pressure. So what's happening is, as we widen our rib cage, we're increasing volume here and increasing pressure, and our body cleverly decreases the pressure here by creating a visceral traction. So our fascia and connective tissue actually draw the viscera up the way, and that's what creates a lift in our pelvic floor and the vacuum. So the vacuum is not created by the abdominals pulling in or by us manually pulling up our pelvic floor. The vacuum is created by widening the space here and creating more pressure here, and our body cleverly decreases pressure here. And that's what's actually happening while we do it in basic pressure terms. And it is the fascia and connective tissue primarily that's creating that visceral traction. And primarily it's the parietal peritoneum fascia. So any questions about that? Is that clear to people what's going on? Usually I don't bombard my clients with this information, and I say it much more, I don't exactly tell the truth in all its, manifestations. So what I say is this, I say, here is your thoracic diaphragm, here's your pelvic floor diaphragm. As we inhale, they stretch out, as we exhale, as we inhale, they move down, as we exhale, they move up. And it's not strictly speaking true, but it is a bit. So inhaling, exhaling, inhaling, exhaling, inhaling, exhaling, and then we perform our apnea, and that lifts everything up. And that's why I explain. Because if I start going on about central diaphragm tendons, pulling the diaphragm down, increasing the pressure here, and parietal fascia, Jimmy, I'd lose them. They would glaze over. But you guys need to know exactly what's going on in their bodies and yours. Okay, any questions about that? Because it is a weird one. Okay, I don't know if that's a good thing or not. Hopefully that's a good thing. So now let's go back and do it again.
So just so when you inhale, it drops, and when you exhale, it lifts.
Yeah, so your diaphragm actually pulls down, yeah, when we inhale.
Yeah.
And it does a weird connection with the organs and things. There's other stuff that goes on, but yes, essentially it pushes down. And as it does that, we have a reciprocal movement. So what's happening is our diaphragm is actually contracting as we inhale. And our pelvic floor is lengthening, eccentrically lengthening. And then as we exhale, our pelvic floor is actually contracting, and our diaphragm is actually eccentrically loading or getting longer. So we've got,
that's why we essentially load on the exhale in Pilates, because you've got the internal strengthening.
Yes, so there, but it's why it's also in personal training, and why we tell people to exhale on effort, is because already the body's doing both these things. It's already contracting the pelvic floor, and it's also, because we're exhaling, the coccyx is actually coming up underneath the pelvic floor, and the sit bones are drawing into the center. So we're getting this real groundedness underneath us on an exhalation, which is why we do things on the exhale, yeah. Whereas on an inhale, your tailbone is actually opening a little bit and your sit bones are actually widening as the pelvic floor lengthens. So we've got this really cool, it's like our whole pelvis kind of opens on the inhale, the bottom of our pelvis opens on the inhale, the top, the ASAS bone actually draws in on the inhale, which allows the abdominals more space to inflate for the breath. And then as we exhale, the ASA bone pulls apart as the sit bones draw in, because they're part of the same curve, and that creates, and then the abdominals are pulling into the center, and this pushes all the CO2 back out of the body. So we've got loads of really a complex system going on when we breathe. That's pretty neat and pretty cool. And my clients would just go, oh. So yes, Suzanne.
Do all the diaphragms move in the same direction all the time?
Yes, but they do different things. So this one is contracting on the inhale, and this one is lengthening on the inhale. This one on the inhale, the epiglottis is a whole series of different things. That's like the laryngeal diaphragm in here. As we inhale, it's kind of opening as well, lengthening, and as we exhale, it contracts. So when we, when we exhale, it contracts because that's what gives us sound. I was just trying to make sure I get it the right way around. And then we've got a diaphragm in which the cranial sacral therapists work with, which has its own pulse as we breathe. Which you can actually, once you hear it, you can't ever unhear it. So, if you want to hear your Dura pulse all the time, come back to me and I'll teach you the exercise, but it's not for now. But if you don't want to hear it all the time, let's leave that one alone. And then our feet actually, as well, as we inhale, our feet should be responding too. So as there's a diaphragm in our feet as well. So you've got this idea that as we inhale, your feet should almost be spreading out or letting go, and as we exhale, the arch of the foot comes up. So we've got this whole breath through the feet and through the hands as well. But that's for another day as well, because we've got lots to go through today already. So now we know what's supposed to be going on in our body. Let's come back down to the floor and try those 3 breaths in the apnea again. And just now you've got it in your head, I want you to come back to really basic, inhaling your joy, exhaling your calm. So we really talk to the nervous system. And then at the end of that, pause and widen your ribs, choosing whichever method worked for you. Yeah. Remember, as you do the apnea, to check in with your jaw and make sure your jaw is relaxed. And also your eyes. We want nothing that signals danger to our body when we're doing these exercises. So things like a tight jaw signals danger, strained eyes signal danger, curled toes signal danger, tight fists signal danger.
Mm.
And And once you've done one, do another one. Just go through it again, just nice and slowly. And remembering that what we're doing is widening the ribs, and the widening of the ribs is what's doing all the cool stuff. Once you finish your second one, just releasing and coming up, sitting, and if you've got any questions, ask. And then we're going to do a couple of releases for your rib cage and diaphragm before we break for lunch.
Hi, may I ask, if I was trying to teach my normal Pilates class, because, you know, the point I think for me for doing these classes or workshops is that I can put it to my clients. So I would say something like, as you all know, as you breathe in, your diaphragm goes down, and as you breathe out, it goes up. Therefore, that's when we gently pull our tummy in. And so I'm going to teach you a slightly different method where you do all that, but you don't think of pulling your tummy in. You would just do 3 lateral breaths. On the last one, you would hold it. You don't breathe in through your nose or your mouth. You just hold it. Try and expand your ribs. And when you need to breathe, just allow yourself to breathe. Is that kind of...
Absolutely perfect. Well explained, Carol. Really good.
No, because I wasn't too sure. That's why I asked if I was...
And I mean, I combine it with Pilates poses because I'm still to do my exam, which I've been saying for ages, and she is honestly still letting me do my exam from BASI. I did my training with BASI. I'm terrified of doing exams, so I'm really terrible at doing them. She's like, just bloody do it, Abby. I'm like, yes, I will. But yeah, so for things like when you do supine twist here, they're called different things in BASI. Yeah, so yeah, hip rolls for you, supine twists for them. When I do them with my clients, I'll do an inhale and then an exhale. And I'm thinking about the ribcage expansion while they do it. Inhale, exhale, pause, and then the apnea. So I tie it, so you can tie it into what you do already. Yeah. There's no reason for it. I'm going to teach you a whole heap of poses, but there are a whole heap of poses that you can use it in already. Things like pelvic curls as well, or bridges in personal training. I mean, you can do 3 breaths here and then perform the apnea and then come up into the bridge, you know, or you can come up on the bridge on the last exhale and then come to the top and perform the apnea. So if you think about how you can actually put this into your classes, so you can mix everything together, and that's ideal. And then you can add the poses that I'm going to teach you, because we actively engage different muscle chains, but you don't need to necessarily do that. What we're trying to get women to do is trying to connect their pelvic floor with their diaphragm and the rest of their body. Overall, that's the most important thing, you know? So yeah, good question. Sophia.
Sorry, just ask again. So I think someone else mentioned as well, I couldn't really hear the answer there when you answered them. I think probably because the noise of the kids and the husband in the background, but there we go. But when I do the sort of the widening of the rib cage, I can feel it up here. I mean, this is my tight space anyway, so this is where I would feel pain and get headaches anyway. But is that something you can sort of train to release, or is it just what's going on up here? Because it's not really sort of front, it's more kind of back.
Here.
No, it's the further back, so kind of more kind of up top here, yeah.
Yeah, so in this area here. So when we come to add the arms to this, you'll find that will go. So it's just the tension patterns that you're holding. Lots of people get this when they first do it. The other thing that might be happening, Sophia, when you do it, and I'll have a look when we come back as well, I'll have a look at your apnea, is that when you go to do the apnea breath, you might be going into old habits. So what you might be doing is widening the rib cage, but also using the scalenes to lift. Probably. And I think that's probably what's happening if you were already in upper
chest. I was trying to move my arms around and kind of, because sometimes even just holding them here, lift your shoulders so you feel really tight. So I kind of tried to leave them down just to see if it changed, but it was still kind of feeling a little bit tight up here. But like you said, it probably is still kind of the old pattern of using.
I think it's probably your scalenes kicking in, and that's probably what's happening. Happens a lot with people to start with. What you can do as well when you're just doing the apnea on their own is you can actually have your elbows on the floor and your hand here. So this way it's really hard for you to like recruit your shoulders and your scalenes. So it kind of takes that out of the equation. So sometimes that's a good way for you to kind of hack into just using the rib cage.
I get a tension in my neck when I do that as well. But I found when I did it exactly as you were doing there, and I felt like my elbows were widening. It's almost like as if you're doing a diamond press, and then it released it, and then it managed to get the ribs to really move by just my elbows widening. But is that a good thing?
Yeah. So when one of the arm positions that we use, which I'm going to teach you after lunch, where we internally rotate in the glenohumeral joint, what we're doing here is we think about pressing the elbows out towards the side slowly. And so what we're doing is an active stretch towards the side through the elbows and through the shoulders, and it stops you from being able to over-recruit the scalenes.
I think that.
Yeah. But basically you get on that, Amanda, doing it that way anyway.
Brilliant. Thank you.
Okay, so any other questions?
Do you talk about the sphincters at all?
Do I talk about the sphincters at all? I talk about the sphincters a lot, but generally not at the beginning. I have a whole like visualization I get my women to do about individualizing, activating their sphincters. I don't talk about it in a Kegel sense at all. No, I talk about and I talk about this bit in this next course, but you do have active control over your anal, the external anal sphincter is something you can really visualize and focus and move, and your vagina is a muscle, and you can activate it. So I can send you, I'll put it in as part of the video things, because it's quite a, my clients all wanted me to do a video, which I just find really weird, because one of them was like, oh, when I'm having sex with my husband, I'd like to try this out. And I'm like, but yeah, you have my voice in the background. Well, anyway, anyway, I did it, you know, so God knows where it's being played. But yeah, I get them to activate the vagina as, you know, as muscles, but then you can also do it with your urethra as well. But I've got a little video of me talking through it.
Thank you.
Which I'll share. Yes, Hannah.
Oh, sorry. Just going back to the apnea breath, one thing I was finding myself as we were practicing is the longer I was holding the breath, the more intense the sensation was becoming. It sort of felt better. Is that normal? Is it just to get your body getting used to it and that kind of thing?
No. So the longer you can hold for, the longer you can slowly open your rib cage for, and the longer you can hold that slow opening of the rib cage for, the more activation you're going to get from your pelvic floor and from your transverse and from your obliques, because they are mainly made up of slow twitch muscles, which means that they take longer to fire. They also take longer to tire because they're more tonic muscles. So it's made up more of tonic muscle groups. So if we were to open the ribcage really quickly, we'd only get the 25% of fast twitch muscles activating. The longer you take to open your ribcage, the more active engagement you will get.
Okay, because I've seen I've just seen on internet and stuff that you can see people doing it, and it's like that's not what I was experiencing at all.
No, and just don't do it that way. So I always say slowly open your ribcage. The ones that are doing a really quick active stretch, actually before we break, we'll do this. So I teach an active stretch of the ribcage, which is what Marcel Caprice teaches, which is what Low Pressure Fitness teaches. However, in the UK, we also have UK Hypopressives who learned with Tamara and Pitti when they didn't speak very much English, which is why I think this maybe got lost in translation. I'm not sure. I just treat it like they've got a different school of teaching, just like you've got different yoga schools. But what they do is they do recoil apnea breath, which is the quick thing that you're seeing, Evie, Hannah, I think. So
Sorry,
and that's okay. We'll do. I'm remembering it's Hannah most of the time. So we'll have a shot of it. Now, what they also ask you to do is a forced exhale, which we've already experienced is not great for pressure within your body. So they do 3 breaths. So it's an inhale. I'll walk through and get you to try it. So it's an inhale, an exhale, inhale, exhale, inhale, exhale. Close your ribs really hard down and then just let them do their thing. You don't do any active engagement at all. And sometimes that's what you might be seeing, but other times it could be just people like not realizing that if they do it really fast, Hannah, they're not going to get the same engagement. So have a shot of the passive rib cage opening, and then we're going to do a quick fun thing before lunch.
Can I just ask, all the
Yes.
different analogies that you gave to try and get that idea of are you going to be including that somewhere for us to?
Yeah, I think they're all actually in the sheets that you've been sent. There's a whole list of different things. I think I wrote them all down. There's a picture of maybe an umbrella or something. I'm not sure what I put as a picture. But I think there's a description of them all.
There is.
There.
What's that then? Thank you.
I'm hoping. I'll try and find the page while you have a practice of that. Give me a sec. I'll pop over and look at it. Yeah, there is definitely a description in there of them all.
Brilliant. When I do the one when you say cue the rib cage closure, of course, that's cued a lot in Pilates to get that rib to hip connection to get into your center. So to try not to use your abs when you're trying to do that is almost impossible, isn't it?
Yeah, to try and do, yeah.
When you cue the closing the ribs, the rib cage closure. So it's almost like what you're doing is so opposite to what we would normally be cueing as far as engaging the transverses, for instance. But actually, you do really feel it when you're expanding. But when you're in the back of the ribs, that's kind of blowing my mind.
Yeah, so it's like, I mean, it can, yeah, it's slightly differently cued, definitely. I mean, what we're looking for is we're looking for a more kind of movement orientated approach to finding center. Rather than thinking about having to hold tension to find center, we want people to be aware of what muscles are where and how they're holding themselves more. I guess, yeah, much more that way.
So much more functional anyway.
Yeah, because I mean, when we walk and move, everything we do, our rib cage is continually changing shape. And when we move, if we twist our rib cage to the left, our pelvis twists back, turns back, and our pelvis here turns forwards. So we've got this constant synergistic movement pattern that we need for when we walk and do anything functional. And it's kind of thinking more about that as we do it. But we're going to do a nice warm-up using them when we come back after lunch. However, I want to do, yes.
Sorry.
Catherine. Yeah, no, Catherine was
Can you just re-cue that last exercise for me?
Oh, that last one, yeah. So you do two normal breaths. So you inhale, exhale. Inhale, so 2. Exhale. Inhale. Squeeze those ribs shut. Exhale, 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 exhale. And then close your mouth and nose and don't do anything. Just allow the ribs to do their own thing. And some people will get a really big recoil and some people will get nothing at all. But you're not getting that active engagement of the serratus, which is the active engagement of the serratus, which feeds into the back muscles, which feeds into the rib cage, which feeds into the obliques, which is what we're looking for to create that actual vacuum where we lift the pelvic floor, kind of through the rib cage expansion, through the diaphragm. Yeah, Catherine, you have a question.
Yeah, sorry. So I feel like internally I'm kind of feeling like it's happening, but when I place my hand just gently on my belly, I'm not feeling any of that kind of drawing up.
Remember the pictures from the beginning. Yeah, what's really important is how it feels inside your body. Like super, super important. If anything, if you look in a mirror when you do it, what you should be seeing, so this is what I get my women to do, what you should be seeing is when you inhale and exhale, your belly button should largely stay where it is. But when you do the apnea breath, because what's happening is we're getting a traction and a pulling through the fascia, and this fascia line that goes, we've got a fascia line that actually comes from your back and goes around, but simplest form, it comes from the top of our bladder, and then it comes all the way up to our belly button and then through the round ligament of the liver. But when you do your apnea breath, you should see your belly button changing shape and moving up a little. You're not going to make it do that, it's just doing that naturally, but that's a way for them to check. What should never be happening is it should never be going down the way, like never ever down the way. And that's the biggest thing to check, rather than thinking about how concave your body is getting. I mean, mine doesn't go concave at all. Just doesn't, it looks really pathetic.
Yeah.
Totally like Yeah, it's not doing it at all. Yes, Amanda, you had a question.
I've gone off into what you were talking about there now.
Okay, so I don't want to do this straight after you've had lunch. So we're going to do a nice release for your diaphragm. A lot of people come with exceptionally tight diaphragms because they've just not been using them. There's been no movement in their rib cage at all. And in daily life, we should be having a little movement of the lower ribs all the time. You know, we should be having this active, you know, we should be breathing with our rib cage, not like this. Because some of my ladies are like, should I breathe like this all the time? No, but you want to have this little movement of the rib cage all the time when we're breathing. But let's release it. So we're going to do a really fun thing to release our rib cage. Our rib cage a little bit, but mainly our diaphragm. So we're going to come standing. And I use this as a warm-up at the beginning of classes. And before we do it, I'd like you just to take a breath, the way we've been thinking about breathing. So lower ribs, back of our ribs, sternum. Take a couple of breaths and just feel how your diaphragm and your rib cage feel when you're doing this. Just remember how they feel. Now what we're going to do is we're going to bend our knees. So we get flexion at the knees and flexion at the hips and flexion at the ankles. And then all I'd like you to do is just bounce, like you're bouncing. So when we bounce like this, we're already bouncing and engaging our diaphragm, but we can't really tell it very much. So we're going to make it work a little bit harder. And we're going to add, so pause for a moment. We're going to add this sound. I want you to practice this sound as well. So we're going to add this sound as a continuous sound. So it's continuous sound. So now bend your knees, and get your flexions, get your nice relaxed bouncing, and you're going to make the sound. When you need to inhale, do. Okay, so what this is doing, they're all laughing at you, Sophia. What this is doing is it's starting to create that vibration in the diaphragm, and it's making your diaphragm start to work as both a phasic and a tonic muscle, which is going to start releasing it a lot. Now we're going to add a little bit more to this one, so exactly the same thing, but this time when you start to make the noise and you're bouncing, you're also going to just allow your body to come to the front and flop like this, and then come back up again. So you're going to come up and down while you make the noise. So and relax. Now, which is fun. It's a fun exercise, and it's really good for breaking the ice in a serious class. So now, I'd like you just to take a couple of breaths and just feel how your body feels. I mean, that was a really short release, but you should hopefully feel that the breathing feels a little bit easier, even with that tiny short release. So I'd usually do a few more rounds of that with my classes to warm us up, and I'm going to show you a few more warm-ups when we come back, because thoracic areas are notoriously tight as hell, and in order to be able to get proper functional movement of the diaphragm, we need to also release it before we start playing with it. Did everybody notice a bit of a difference there?
Abby, I've just started doing Qigong, and they do a lot of this sort of sound, movement, shaking.
Yeah.
It's definitely, it's an energetic thing that goes way back.
Oh yeah, there's actual sounds that vibrate different organs.
Exactly.
I originally trained as an actor and in London, and when we were doing the Alexander technique as part of our stuff, it was we learned different sounds for different organs and different characters, you know. Cool,
yeah.
man.
Yeah, that's cool.
Yeah, so this all ties in Qigong. A lot of Qigong ties in. I do a lot of tapping and things, which is all really Qigong as well. Yeah. Mm-hmm. These things all cross over and work really, really well together. The combination is it's the combination we're looking for, Amanda.
Brilliant.
Of things that we learn.
It's lovely to see things coming together.
Yeah, it's good, isn't it, when it happens? Yeah. So, any questions before we break for lunch, guys? I'd like you to eat right at the beginning of lunch, so you've got time to digest. Don't eat too much, because we are going to be doing apneas afterwards, but I'm going to start with a bit of a warm-up and teach you some postures, possibly without the apneas, and then we'll add them in. Just give you time to digest your food. We are back. It's supposed to be an hour, but I'm hoping you'll take 45 minutes because I've got loads of stuff to get through.
Okay.
Cool. So great. We'll be back at 10 to 2 then.
10 to
So
2.
10 to 2. Yeah.
Lovely. Thank you.
So, excellent. Mwah. Take care. Bye, guys. Hannah, did you have a question? Cool. Okay. I think my audio was probably off there, talking to myself. We've got some time for some questions, and also we're going to go through the last of the slides to give you time to digest as well. And yeah.
Can you tell me where you found your cues for the way you try and express how to teach the rib expansion? I was having a quick flick through, but I haven't seen the list that you said you found.
We're going to go through it in a minute anyway, but I can share the screen. Hold on, I'll share the screen and show you the picture. Here.
Is it on?
Helpful visualizations.
Oh,
so it looks like that.
Haven't seen it. I should take a picture.
So it is page 40. It'll be of 52. Do you have that page?
That's what I'm trying to find. Page 40.
I'm hoping that Lee sent you the right one and not the old one.
I don't think I've got that one.
Has anybody got that one?
There's no page numbers on here.
Yeah, it's the picture. The picture's got a picture of a flower and an umbrella.
Will this be in today's book, not tomorrow's?
Yeah, today's book.
Yeah, it's definitely not in the foundation book then.
So he sent you the old one. He keeps doing it with this with the fascia book as well. He keeps sending the old one and not the new one. That's so, okay, guys, don't worry about it, because what I'll do is I'll just send you a digital copy of the slides.
Okay, because that was so helpful, but I can only remember the one that resonated with me. So
okay, so it's fine. Don't worry. So I'll send you, when I send out the recording with everything, I'll send out a digital copy of that too. So
helpful.
I'll add it to my list.
I'm gonna have a lot of homework.
Have you got the old one that looks kind of, it won't have the contraindications in it either then?
No, it hasn't.
Yeah.
No.
Yeah, that's the old one.
Yeah.
Okay, that's fine. What we'll do is we'll go through my slides, and then when you get them, you can, like, you know, enjoy them.
Yeah.
So digital copy of level 1, and also for the one for tomorrow, Amanda, let me have a look at that one. Which one have you been sent? Just so because what I might do is just send it out, and if you open it up for me, could you just see if it looks quite dark or white in the pictures? Oh, maybe he's got the right one for that and the wrong one for this one. Ah, yeah, that's the right one.
Okay, so it's just the first one I've got wrong. Has everybody got that wrong one, or is it just me?
Yeah.
Has everybody got the wrong first one?
He's probably sent it all out the wrong. So I will, Lee sends them out. I know he does it rather than Thomas. So I will send it out as a digital copy. No, I'll send it as a digital copy. It's all good. Let's not worry about it.
Yeah, exactly.
Yeah. Okay, any questions about what we did, about how it felt?
You mentioned something about the pause of breath being, was it resilient or tolerant to CO2? I didn't quite know what you meant.
Yeah, so when you pause between breaths, you're building your tolerance to CO2. Yeah, so you could use resilience as another word. You could use, they both work, you know. But what is that? It's the tolerance to CO2 that it's the CO2 leaving your body that helps to release the ATP energy cells, so it gives you more energy. So the slower you can bring your breath, the longer you can bring your exhales, the more energy you're going to have. It's also the more CO2 tolerance you have, the better your sports stamina will become as well, and the better your recovery times will become. And when we're doing the apnea breath, we're also doing a little bit of hypoxic intermittent training. So, and we're going to talk a little bit about this now in the slides that are coming up. So we're doing, so we're not doing it to the same degree as athletes do it too, but we're doing it intermittent, and it's being shown now to have results for crossing the blood-brain barrier, and they're looking at intermittent hypoxia as being something to use for things like Huntington's and Parkinson's as well. So this is a really new area of research. So I'm just checking, my kid's sending me a message. My kids are terrible for, no, it's okay, it's not them. I just left them.
That's
Sorry.
it, we're going to do a lot of breathing, just to run in and out through the nostrils as well, instead of out through the mouth. Presumably that's for the same reason, is it? Or is that
Yes. Yeah. It's also so that you use the right muscles in your body when you're running as well. And it's so that you engage more of the serratus, the back muscles and things when you're breathing. The other amazing thing about just doing nasal breathing is you do a more of a vibration of the vagal nerve, which is one of your 10 long cranial nerves. And the vagal nerve is called the vagal nerve because it's a wandering nerve, so it innervates most of your organs in your body. And it also has more afferent nerve endings, so it sends 80% of its messages go towards the brain, 20% come from the brain to it. It's where the books like the gut brain come from and things, you know, that discussion of having so the afferent and efferent nerve endings. So all of that's, I mean, pretty, yeah.
The other thing is, you said relax the jaw when you were doing the initial thing. Do you have to have the mouth open then?
No, it's just really relaxing the jaw.
Don't necessarily, because otherwise you start to breathe out through your mouth anyway, wouldn't you? So
yes.
Okay, thank you.
And it's really the relaxing. If you tension your jaw, you tension your pelvic floor. So and it's one of the ways that I used to get women who were really worried about their pelvic floor, my ladies, to, if they were lifting shopping and they were like, I can't do it, and just exhale, I get them to press their tongue to the roof of their mouth, because that will help stabilize their pelvis, and just makes them feel a bit more confident about the initial lift. And then I get them to breathe regularly. But for that initial lift, just pressing their tongue against the roof of the mouth helps stabilize everything.
That helps to balance as well, doesn't it?
Yes, yeah, it can do, yeah. Tapping can help balance better though, Amanda. Yeah.
Good to know.
Yeah. So, any other questions?
Yeah, where
Anna?
does the name apnea?
Apnea, it's a pause and breath. So apnea is, it's like sleep apnea is a pause and breath at nighttime.
Okay.
So apnea just means a pause and breath.
Okay.
Yeah.
All right.
You don't have to use that. I mean, quite often with my ladies, I just call it a breath pause. A breath pause with a rib opening, because sleep apnea, it has kind of negative
connotations. That's what I mean. Yeah. The term is alarming.
For some people, yeah. Unless we
Okay.
re-educate them to see it as a positive thing. So
okay.
But yeah, a pause and breath or a rib stretch, you could just say.
So similar in yoga to the kumbhaka, that pause, that.
Yes.
Okay.
But without the rib opening, that would be without the rib opening. Yeah. Pause and breath, yeah. Okay. It's also in just standard breath training. It's a breath reset, is that pause and breath as well, just to reset your breath. Yeah, but yes, it is. Yeah. There's so many crossovers for so much of what I'm teaching you today. You know, this is just one combination of all the different things that we can have and put together.
Can I just ask, Abby, you said about the tapping helps balance. Will you do that today?
Yes, we're going to do that as an exercise when we warm up just now. I'm going to talk about that as well, why that works, and it's especially important if you've got hypermobile population. And I'll explain why. Yeah, well, the majority of women with pelvic floor dysfunction and prolapse are actually hypermobile. So I've got it on my form, my admittance form, is because they naturally have stretchy ligaments already, and so there's just more stretch in giving them. It's in the 12 years that I'm teaching, 70% of the women that I encounter have some degree of hypermobility. 30% don't know as well. So, you know, it's not a caveat or catch-all thing. And not all hypermobile women have prolapses, but it seems to be a majority for me. And I'm also hypermobile, so, you know. But the other thing with hypermobility to remember is some parts of people's bodies are really, really, they give way easily, but other parts are really stiff. So it's just to remember that as well when you're working with hypermobile population. When we look at the poses, I'll talk a little bit more about how we keep it so it's good for them too.
That'd be amazing.
Cool. Any other questions? Okie dokie. So I'm going to fire into the slides, and I am going to talk. We'll talk through all the stuff we need to talk through, and then we're going to get on with some more practical, because the practical is where we learn the most. So I'm just going to share this with you guys. I'm going to put it on slideshow, hopefully. Oh, it's lots of wee bits everywhere. It's misbehaving now, my thing. That's what happens. Hold on a second. I'm just going to put us over there. There we go. Oh no, now what's happened? Now I can't see you guys. Now I can see you. Cool. Right. I'm just going to play from current slide just now and I'll go back into it. Gosh, it keeps hiding you guys. Where are you? How am I doing this? There. I keep shrinking us into tiny little people. So I'm just gonna move this around so I can use slideshow. Right. Now we should be cooking on gas, hopefully. There we go. Okay, can everybody see that changing screen? I'm hoping. Yeah. Cool, excellent. I'm going to go back to where we were. Okay, here we were. Okay, and I'm going to put it so I can see you guys again. Good, perfect. Okay, so we're going to be back with the diaphragm. So the diaphragm is a muscle that separates, it's a thin sheet of muscle that separates it's not just muscle, it's also a massive tendon in the middle that separates the abdominal cavity and the thoracic cavity. So it's like the roof and our pelvic floor is the floor, if you think about it that way. It has connections throughout the body and creates activations in the vagal nerve, psoas muscle, adrenal glands, this is what I need to talk to you about as well, and anterior fascia chain that runs through to the falciform ligament of the liver down to the bladder. As it moves, it massages the heart, the upper abdominals, and it helps mobilize the lymphatic system. So when the diaphragm moves, when we open our rib cage, so a lot of times in menopause and perimenopause, women have adrenal fatigue. So their adrenals are pretty depleted. And a really nice way for us to work with the adrenals is to massage them gently. Now, when we widen our rib cage, when we're doing our widening for hypopressives and closing our rib cage, what we're actually doing is as we draw the rib cage open, the diaphragm's descending and it's massaging the adrenals. And then as we exhale, it's letting them go. So we've got this pulse through the adrenals. That's a really lovely way for helping to calm down an overactive cortisol response adrenal system. And a lot of women are stuck in that kind of cortisol response because, you know, they've been up with kids, they're working, they're running a family home, they're looking after kids, they're running them everywhere, in which way, and they're trying to do so many things that they end up with this huge stress response. So it's a really lovely way for the adrenal glands to be massaged, because during perimenopause, when your ovaries stop producing the hormones, we're supposed to have this beautiful, gentle shift over to the adrenals doing it. But for many of us, our adrenals are already tired and shot. And so this creates a mismanagement within the endocrine system. And doing the hypopressives, the slow breath work, and doing it regularly helps, again, to create a sense of calm and balance within that system. It's one part of the puzzle. There's a lot more that we have to do to help with adrenal fatigue, but it is a really positive part of the puzzle and something people can physically do, which is nice. The other thing that happens as well is that the fascia that covers the heart actually merges into the top of the diaphragm. So that when we inhale and open our rib cage and the diaphragm draws down, the heart also draws down. And then as we exhale, the heart moves up. So we're getting this beautiful massage for the heart every time we breathe as well, which again is just a lovely way of calming down our hormonal system, so one of the contraindications is high blood pressure. However, so you can't do the apnea if you have unmedicated high blood pressure. So if you know you've got high blood pressure, you're not on medication for it, we don't recommend doing the apnea breath. Because for a period of time while you do the apnea breath and shortly afterwards, it raises your blood pressure. So we recommend you don't do it. However, over time, even people who have high blood pressure, if they go back and get checked with their doctor, all my clients have reduced their blood pressure down so that they've then been able to go on and do the apnea breath. So again, when people come to me with hypertension, I get them to go back regularly to get checked with their doctor, because usually they have to lower their medication because they're slowly release the hypertension in their bodies. So it's definitely, there's so much in slow breathing, but that's one of the things. The other thing I wanted the falciform ligament. So this was an important one as well. So the falciform ligament goes around your liver and then continues up through the diaphragm to the heart. But the falciform ligament is a ligament that goes around the liver. But this falciform ligament attaches to the anterior chain, which is kind of like a fibrous fascia chain through the front of our body. And we know that it's there, you know, it's been cadavered out. It's been, the anatomists have chopped it out and seen where it is and what moves. So, and it comes down the front wall and it comes all the way to the belly button. And then from the belly button, it becomes what is called the uricus, or the medium uricus while we're in our mum, in utero, and the medium ligament afterwards. And this ligament actually comes from the belly button to the bladder. And it's got a continuous journey that comes all the way around to the sacrum at the back. But for now, this is all we really need to know about. So when we inhale and exhale, when we inhale and the diaphragm flattens down, this anterior chain releases too. So we get this lowering of the pelvis and this ability for the pelvic floor to then be able to lengthen. Then when we exhale and the diaphragm draws up, the pelvic floor draws up, and the bladder draws up, being drawn by this falciform ligament. So we're getting this really beautiful activation through this anterior chain with the motion of the diaphragm. And remembering from the start, we're also getting the same kind of activation from the psoas that comes from the back of the diaphragm down. So we're breathing, and as we open our rib cage, our muscles are moving to the sides and the front like this. So we're extending and contracting, extending and contracting. At the same time, as we inhale, we've got this lowering, and then this exhale, we've got this lifting, lowering and lifting, lowering and lifting. And at the same time as that, every time we inhale, we've got this widening of the sit bones and drawing back in of the sit bones, this curling out of the coccyx and curling back in of the coccyx. So we've got a relaxation, and not so much a relaxation, but a letting go almost or of the paraspinals. And then on the exhale, they're lengthening. So we've got a shortening and lengthening of the paraspinals going on. And this shortening and lengthening allows space for the ribcage to open and then close as well. So we've got all these amazing things in motion when we breathe. And they're all driven by the movement of the diaphragm. So it's really important that we get even just a pulse within the diaphragm when people are breathing in regular daily life as well. So although we're training at an extreme in hypopressives, what we're looking for is for people to take that extreme and kind of tone it down for their everyday breathing. Here's a lovely video again of it in motion. You can see just how far it descends, and this grey matter in the middle is the central tendon. And going through the central tendon, we have the esophagus, the vena cava, and there's a big one I'm forgetting for a moment. Yeah, I've got a picture because I always do this. Okay, this is why I've got a picture. So here, this aorta here of the heart, the aorta actually goes through the back of the diaphragm. So it doesn't actually go through the diaphragm itself, because otherwise every time we breathed, our aorta would be getting squeezed and we'd be having issues with the blood pumping to our heart. We have the vena cava, which does go through our diaphragm. So the vena cava comes through, so that's a big vessel for our blood. And our esophagus also comes through the diaphragm. The esophagus has its own little loop here. And this is, again, this loop here is to, one, stop it from squeezing too much when we inhale and exhale, so we don't have acid reflux all the time. And two, it's to create enough tension so that we also don't have acid reflux. If you have a diaphragm that's not been working very well, a lot of people that I come across have hiatal hernias, where their stomach lining herniates through the diaphragm. Hold on a second, my thing's done something weird. Hold on. My volume will stop working. Give me 1 second. I love technology. Okay, we're back. I think, oh no, we were back, then we weren't back. Yes, we're back for now. Let's see what happens. Okay, so, and when my ladies come to me with hiatal hernia, they get told they just get sent away with hiatal hernia with some tablets to stop acid reflux and no exercises. But as they practice hypopressives, they find they have fewer and fewer incidences of issues with their hiatal hernia. So I start them though with no inverted poses. So that's important to start with. They don't do anything where they're inverted to start with, because otherwise the slide of the stomach lining up through the diaphragm may happen. So I start them supine and in upright positions initially to start with. We can see the connections here, all the connections. So this is a costal ridge. So this is the ribs going round. So we can see just how connected the diaphragm is to the rib cage and how important our rib cage mobility is for diaphragmatic movement. We can see here the quadratus lumborum muscle coming up, the psoas muscle coming up as well, and just all the amazing connections to the diaphragm. Any questions about the diaphragm at the moment? Cool. We're going to release it in a minute again. So we've done a little bit of a release. We're going to do a bit more. So role of the diaphragm in the body is for breath, to stabilize the trunk, so it stops us from carrying on rotating for forever, and places pressure on the esophagus to prevent acid reflux, phonation for speaking, and prevents herniation of the abdominal organs into the chest cavity. The central tendon contracts. So this white stuff, that's our central tendon. And some people can have a small central tendon and other people have an absolutely enormous one. So we've got the same things in our bodies, but sometimes they look different. So it contracts as we inhale and releases as we exhale. Here's some more pictures to show you how interconnected it all is, which is pretty phenomenal.
Wow.
I know, eh? So this is what I mean. So this is the stomach here. So we've got the stomach here. So can you imagine when you're inhaling and widening your rib cage, how the top of the diaphragm will massage the top of the stomach? So we are belly breathing, but not pushing our belly out to the front. We're breathing into our belly and into our organs. Okay. So looking at the poses and starting to think about the poses we're going to learn shortly. We use the abdominal vacuum, which is what you've been learning, which is the apnea breath. And we also use a lot of dorsiflexion. The dorsiflexions, we dorsiflex at the ankles. So we dorsiflex because it's shown that as we dorsiflex at the ankles, we, one, activate the posterior fascia chain, and two, we create an activation that goes from our big toe all the way up through to our abdominals, activating our transverse abdominis. So this was a study, and it's in this one. I hope it's in your one, but I will send you this anyway. So for you to look at if you want to have a little bit more information about that activation and why we do it. And there's some more information here about dorsiflexion and ankle activation too, with some more studies to have a look at. So the dorsiflexion that we use is so that we get the activation through the posterior chain, but also the anterior chain too, from the heels and the toes all the way up through our body. The tongue is really, really important. So making sure there's no tension in the jaw and the tongue. And we're going to do a fun exercise for that, hopefully just at the beginning now as well. So we're going to use it as a warm up. I'm going to remember that by putting it on my thing because I keep forgetting. Eyes and the pelvic floor. Now, I'm going to talk about the tongue in a minute as a release, but eyes are really important. If you think about apart from your neuroception, so apart from your neuroception that can sense danger around about you, when you get a feeling that something's not quite right around about you. So your body's giving you all these messages from the external world all the time. The other thing that happens initially is that we see. And so if we see a tiger, that sends up your eyes, there's a system behind your eyes that sends a message back through your grey matter to your amygdala. And I think there might be a picture of amygdala, might be in the next session. So the amygdala then sends a message to your pons at the base of your skull. And it sends a message saying there's something frightening about to happen. And the pons then sends a message that goes down through your cervical complex of your nerves to your brachial complex of your nerves, all the way down to S1, S2, where you have a little kind of computer terminal called Onuf's nucleus. Onuf's nucleus then sends a message to your body telling you whether it's safe to pee and poo or whether it's not. And sometimes these messages can get mixed up. So sometimes it's actually tension in the jaw, tension in the eyes that can be contributing towards urinary incontinence and fecal incontinence. So it's just being aware that when you're looking at your clients, if they're like staring and they look like I'm not sure what I'm doing, getting them to relax their eyes is a good way to take away that the nervous system response of danger. Get them to think about nice things, or look at a nice picture on the wall while they're practicing, or, you know, I've got like elephants on my roof for when they're lying down. So just so there's something visually there that's nice for them to look at. Okay. Feet and the pelvic floor. Any questions? Sorry, was there any questions about eyes? Eyes. Cool. So feet and the pelvic floor. There are 250 to 300,000 nerve endings in your feet. I learned the other day that there's about 300 million iola sacs in your lungs, which was made my head spin. But there are 250 to 300,000 nerve endings in your feet. Your sciatic nerve ends up in your feet, as do branches of your femoral nerve. So these both go through your pelvis. So we want to make sure that when we start our practice, we warm our feet up, because if we can warm those nerve endings up in our feet and get them activated, then that's going to send great messages back up to your pelvic floor and create that kind of pre-exercise warmth within your pelvic floor. There is a surgeon in the UK who looks at women's feet before he looks at their pelvic floor, and he looks at their pelvic floor to affirm what he's already worked out from their feet. That's how important feet are for your pelvic floor. We'll do a bit when we come to standing about how to stand, but that whole old adage, that old saying, he curled up his toes and died. So that if people hold tension through their toes and hold their toes really tight, that also sends a message to your body that you are in fear of your life. And your body does a cool thing if it thinks it's in fear of your life. It sends you into sympathetic nervous system. Your sympathetic nervous system then protects your heart and your lungs and all the area that's really important for withstanding a dangerous attack. So it prepares you for running, it protects your heart, and protects all those organs. But it does jettison your parasympathetic nervous system. And your parasympathetic nervous system is what innervates your pelvic floor mainly. So your pelvic floor is mainly innervated by your parasympathetic. So it means that if you're feeling anxious and things, your pelvic floor is just not going to be firing the way it should be firing. So we want to look at all the ways we can down-regulate the nervous system so that people feel safe, and then we can start to really work with our bodies. So we're looking at eyes, we're looking at jaws, we're looking at feet, and we're looking at the environment that we put people in when we're practicing.
Abby, do you have any ideas around getting people, helping them to relax their eyes?
So I basically get them to visualize nice stuff. So I've got like lots of nice pictures on my walls, and I get them to visualize lovely stuff. And I get them to partially close their eyes sometimes if they look, you know, if we're doing supine work or sitting work, I get them to partially close their eyes and soften their eyes. But I also want their eyes looking straight ahead, because if they put their eyes down the way, then it starts to create that tilt forward of the head that we're also not looking for. And a cue that I use all the time with women is like, you know, make sure we're gazing straight ahead, soft eyes. Whereas with blokes, I've never had to ask a guy to look straight ahead or look up from looking down. Never. Purely
Interesting.
Female cue. So I'm not sure where that comes from. It could just be from like spending our whole lives looking for something on the floor, like that they've dropped or children have dropped or something. I don't know, you know.
Well, averting our gaze.
Yeah, or averting our gaze, isn't it? It could be a cultural thing as well, yeah. So, contraindications, you don't have them on your list if you've got the list that you've got, so I'll send these out to you. Pregnancy is a contraindication for the apnea breath, but not for the breathing and the postures that we're going to do. Once somebody finds out they're pregnant, the apnea can no longer be performed. It's okay, you know, if they don't find out till they're 8 weeks pregnant, it's fine. You know, the baby's really, really tiny then. The lateral breath is super important still and should be continued throughout. So what the lateral breath, the breathing to the sides and behind and into the upper sternum does, is it means that there's enough space for the lungs to inflate, and it stops the majority of time. It ceases this movement, this forward flare that happens with women when they go into pregnancy. If they can get enough mobility into their rib cage, generally the baby sits much further back. When the baby sits much further back and we're still mobilizing our rib cage the whole way through pregnancy and it's not stuck forwards, then the psoas muscle stays nice and juicy. Now, in holistic birth practices, they see the psoas muscle as being like the runway lights for the baby coming out during childbirth. So if we've got our ribcage thrusted forward and our back's really tight and we've got this really lordotic position, I mean, we do anteriorly tilt naturally during pregnancy, but we do take it to an extreme with this flare forwards. Then what happens is the psoas becomes really tight and it's no longer there as a beautiful, soft, kind of directional light runway for the baby to be birthed through. My ladies who've had a pregnancy and then had done hypopressives and then gone through a second pregnancy while doing hypopressives have all had much, much easier births with fewer incidences of diastasis and no further complications with their prolapses. So this, like making sure or really ensuring and helping that women have this lateral breath during pregnancy is super, super important. I wish I'd known about it before. So I put on that about the psoas. After the first trimester, however, just in Pilates, as in Pilates, there should be no prolonged lying supine due to potential pressure on the vena cava. They can perform the supine pose at a reclined position of about 45 degrees. Any questions about pregnancy? Nope. Okay. These are the other ones that are contraindicated for the apnea, not for everything else, but for the apnea. I'm going to go through each of them. EDS vascular. So EDS is the extreme form of hypermobility, and vascular, it's just the vascular version, not the hypermobile one. Vascular is when the veins and the arteries are super, super stretchy and bendy too. Just about all my EDS ladies I've ever had who've had vascular know that they're vascular. The reason they know they're vascular is because they have other things alongside it, like POTS, which is like tachycardia of the heart. So they'll have other issues going on. They'll know they're vascular. So they can do the breath work and they can do the poses, but they can't do the apnea. Because remember what we talked about, we're increasing pressure in this area. And that means we're increasing pressure around the valves for the heart and the arteries to the heart. And we definitely don't want anything to go wrong there. So just being aware that that's a thing is really important. I've already talked about hypertension. So that's high blood pressure. Just if they're medicated and they've got their blood pressure under control, they can do the apnea. If they've got hypertension and it's not under control, then they can do the breath work without the apnea. And again, that's about that rising of the blood pressure after the apnea breath. Anyone who's had any operation on their heart or any thoracic organ within here, apart from gallbladder removal, which is totally fine, because the gallbladder is just not there anymore, it's gone. Then they can't do the apnea breath. And again, the reason is a precaution. They would probably be all right. However, I'm in the business of making people well. I definitely don't want anything bad to happen to them. So again, it's about that increase in pressure in the thoracic area. So just being aware of that. COPD, my mom has COPD, and COPD, I've just spent time in hospital with her and the COPD breathwork people, and what they teach them is basically the lateral breath we've just gone through, is to get better lung capacity and better CO2 tolerance. So that's what they're taught. So that part of hypopressive is amazing because it's going to keep them moving, keep that elasticity in their lungs. But the breath hold, the apnea, definitely not. Again, they've already got reduced oxygen in their system, so we don't want to reduce the oxygen any further for them. But the breath work, brilliant for them. Yeah, the doctor actually said you should listen to your daughter, which she never does, so And then for years I've told her to do hypopressives without the apnea, and she just refuses. During a flare of IBS or Crohn's, so just during the flare, because when we are widening our rib cage and the pressure is reducing in the abdominals, then there's a lifting up and a moving about of the abdominals, and you're having a flare anyway. It's already inflamed. Let's not push it and make it worse. But all of my ladies with IBS and Crohn's have all had a lessening of symptoms and longer times between flares as they've practiced hypopressives. So it's a great one for their whole system. Okay.
Can I ask, does that include colitis as well?
Yeah, colitis is in there with IBS and Crohn's, yeah. If they're having a flare.
Okay.
Yeah.
Mhm. And if somebody didn't know they had high blood pressure though, and they were to do this, what would we notice? What would happen?
They would feel dizzy. They would feel really, really dizzy. They would feel dizzy and out of breath after doing the apnea.
Okay.
Yeah. I mean, my intake form says, have you ever experienced any dizziness when you stood up quickly, or, you know, so it's in there, so I can kind of screen them beforehand. And then I can have a conversation with them. You know, if they say yes, then I don't actually say, no, you can't do it. But what I say is, like, let's have a conversation about where your body's at just now before they start with me.
Mm-hmm.
Does this have any positive / negative effect on people with endometriosis?
It's great. So it's great for endometriosis because it helps to lessen pain. So the slow breath work and the apnea is great for reducing pressure in the abdominal area. And I know endometriosis can be anywhere in your body, but the pain generally is kind of in that area, in the pelvic area, but not always. And yeah, so it reduces the pain of endometriosis, definitely.
Right.
It also reduces the pain if you have, I had a gentleman who had advanced prostate cancer, and he found that the apnea breath, slow breath work and the apnea breath were the only way he didn't feel pain, and he used it for his end of life care. Sadly, he's not with us anymore. Yeah, so it's great for pain relief as well. This is just an overview of the apnea for you to have a look at so that you've got it, so you can read back over it. And again, it won't be in your sheet, I don't think. So this will be, is it? It's in there, good. Phew, that one's still there. But I'll send you this electronically as well. So again, this is just an overview for you to be reminded. So you've got something to read rather than looking back over videos. This is troubleshooting. So this is things to look out for. This is my child because he does a more dramatic apnea than me. So I used him instead of me. His looks much nicer. You can see his belly button moving up. Nice winding of the ribcage. You know, if I had one like that, it'd be all over the internet. So troubleshooting the apnea. Look out for them using the abdominals to try and lift the ribcage from below. So what people tend to do is they're like that. Oh yeah, I get. And they lift, so they suck inwards and upwards and try and push the ribcage out from below. They'll get a sore back when they're doing that. It won't feel very nice. But you're looking for that being abdominals starting the movement pattern rather than the ribs. You can spot this because the abdominals usually become tense and the ribs draw inwards towards the center instead of opening. Sometimes the secondary accessory muscles are recruited and the rib opening and widening is attempted by trying to lift the ribs straight up from above. And you can spot this because the scalene muscles really fire and they look really great. And I always admire my ladies who have such amazing scalenes because they've worked really hard for them, you know. The other one is flaring the ribs forward instead of widening all the way around. You'll see the lower back increase in lordosis as the spinal extensors tighten. So that's this one. You know, they've done their breast and then they go, all right, apnea. And the chest comes forward. So it's just a flare, and we're not doing a flare, we're doing a widening of the whole thoracic area. And then trying to lift the ribs from the shoulders, you can see the shoulders move up towards the ears. So this one I get quite a lot. So just being aware that there's some of the patterns you might look for. Any questions about those?
No, that makes sense.
Cool. Helpful visualizations, which most of you don't have. Don't worry, I will send this out to you. And this has them all in it. Yeah. And then there's some notes for you to take on apneas as you're doing them. And then we are going to start going through the poses. This is my apnea. Look, my apnea is not very dramatic. It's about the only picture I've ever taken of it. And it took me ages to get it so it looked like anything. So I was like, oh my God. So now you might not have these. So this has got notes for all the poses we're going to cover today. And this is just for you to look back on. And so you've got a visual cue. I'll also send some video help too. So these are the poses we're going to have a look at. And then at the end, I've got a list of all the questions I get asked, which are things like, can I do hypopressives when I'm menstruating? Yes, but it's a personal choice. Just like in yoga, you could do the inversions, but you know, lots of people choose not to. Can I wear a pessary and perform the apnea? Yes, but if you have one you can take in and out, try it without. I've read that you can't do the apnea with a coil. So this is a big new one because so many women are being prescribed the Mirena coil for perimenopause, menopause. Mirena coil has got a huge amount of lawsuits in America for it meandering and slicing through parts of people's uteruses and bladders and meandering into the bladder and things. So there's quite a lot of lawsuits out there. So if my ladies, and lots of women rely on it for menopause symptoms, I just make sure that my women know that they should read the small print for Mirena coil and make sure they're well informed about it. There is no evidence of hypopressives causing any wandering of the Mirena coil. So I just make people aware, and it's on my intake form for them as well. Yeah, and again, it's a massive thing ongoing in America just now, which will probably come over here afterwards. So it's just to be aware of that kind of simmering in the background somewhere. The other question I get asked is, can I do more than 10 minutes a day? Yes, you can, but these are muscles that you might not have used much before. So build slowly and listen to your body. If you've been an upper chest breather for ages or a belly breather that's not used your rib cage, your diaphragm's probably not been used to its limits so often ever before, unless you were running. And so just listen to your body, because the diaphragm is also muscle, and muscles can spasm when you overuse them. Okay. And then the other one is, can I do hypopressives after pelvic organ surgery? Yes, but wait 12 weeks before performing the apnea. And that's the same for after a C-section. So if you've had a C-section when pregnancy, it's 12 weeks after a C-section, and it's 6 weeks after a vaginal birth. And will they help me if it's been 10, 20, 30, 40, 50 years since my first symptoms? Yes, you can do this at any age. My youngest one's been 9, and my oldest one has been in her 90s. So you can use them at any age. And will these work for erectile dysfunction? Yes! And that's us. So we're going to do it all practical now. And I've got a checklist at the end for you all as well. And this is just the checklist of all the cues. And I think that's us for the slides. Oh, and I put this one in for you guys. So applying hypopressive to Pilates and is just following the principles. And I'll let you have a look at them as well. I'll send it out to you. But you want to keep your spine lengthened, line the diaphragms up and engage simultaneously, keep an equal space between the ribs and the pelvis, dorsiflex the feet, keep the eyes and jaw relaxed during apnea breath, create a continuous stretch through the fascia, which a lot of times in Pilates poses you are doing, and use the 360 lateral breath. Ta-da!
Oh, I haven't got the checklist, Abby.
No, we've already talked about that. So yes.
Sorry.
So, yeah, no, I'm here and I'll explain. So
Okay.
he sent you out the old one. So don't worry. However, I am going to send this one out with the email with everything else. So you should have it all. Okay. So yeah, just be aware. Any questions?
Yeah, couldn't we ask Lee just to send us all out the new one?
Yes, you could do, but I'm happy to send the electronic one to you as well, so you've got it now rather than but just ask him to send you out the new one.
Thank you.
That'll remind him that there is a new one. That might be a good idea, Sarah.
Yeah, I just quickly ask, did you say earlier that you were going to talk about how this might help clients with Parkinson's disease?
Yeah, but it's the blood-brain barrier. So I'll send you the research about slow breath work and intermittent. So what we are doing, yes, I'll go through this a wee bit. So what we're doing with the apnea breath is we're doing something called intermittent hypoxia. And it's the intermittent hypoxia that's being shown to have great results for people whose medication is not necessarily, pharmaceutical is not able to cross the blood-brain barrier. So used in conjunction with pharmaceutical drugs with intermittent hypoxia, they're showing improvements in people with Huntington's and Parkinson's. So they're small trials at the moment. So it's a really new area for them looking at, but it's quite exciting because it's the first time there's been a move forward like this for a while.
Yeah, I mean, my lady who's got Parkinson's, who I've been seeing for probably about 5 or 6 years now, I can definitely tell now that her rib cage and her breathing is changing.
Yeah.
And I've seen that in previous clients where like they look like their rib cage isn't moving at all.
Yeah. And you get this as well with MS as well. So it's the keeping the mobilization of the thoracic area is super, super important, and using the breath and the diaphragm. But I'll send you the research paper that I have on this to have a look at.
Thank you.
And was that also for Alzheimer's as well?
Yes, it's for Alzheimer's as well. Yeah. So hopefully they find a way to do breakthroughs with breath, because it's such, it's free. It's free. So it's really important. Yeah. So Sophia.
Just quickly, though, going back to the menstruating and the period part, what would the effect be if you were on your period? Would it have would you feel funny, or why would you?
It's about energy.
Choice, but okay, so it's the energy levels.
It's about energy lines. It's about energy lines. So it's about the whole idea that when you're bleeding, things are coming down the way, so you shouldn't be upside down, because it should be it's the flow of energy. So it's very much from the kind of holistic kind of yoga point of view, yeah. So it's a real choice thing. I mean, I used to just ignore it when I did yoga, but I know a lot of people take it very seriously, that it's about the flow of energy.
Okay.
Yeah.
Right.
It's about meridian points and things. And the more I do all these things, the more I realize that there's a massive crossover between tight fascial lines, where they think fascial lines generally kind of are, meridian points and acupuncture points are all in really similar places to each other. So I used to be totally hardcore gym person who was just like, that's ridiculous. But these days I'm more and more and more realizing that, that was a very naive way to look at the world. The best thing, I think, for pelvic floor recovery alongside exercise is for people to really believe that they can heal. It's a mental mindset. It's very much visualizing themselves being well is one of the biggest things. And it may be a placebo, or it may be just the power of your mind being able, and your body together helping you heal. But it's definitely, my big thing with women is you can bloody heal, and you will heal. Okay, so any other questions before we fire into some practical? Excellent. So let's do it. So we are going to run through the poses. We're going to start standing, because I want you to do some release work standing, and also I'd like you to feel the apnea standing. So we're going to start with the standing poses, and we are going to start with our feet, then our ribs, I think, in that order. And I am going to change my camera and change my audio so you can hear me when I'm over there. Dun, dun, dun. Okay. I'll change camera. Cool. Okay, it seems to be working. Yay. Okay, so we're coming to standing. So feet and mobility in the feet are really super, super important, and I start every session with feet, every session with feet. You can do a myriad of things for your feet. You can do rolling a ball underneath them. You can do scrunching your toes up and then extending them and pressing them down. But my favourite, which we're going to do today, apart from ball rolling, is lifting our toes. So we're getting that neuroception between our brain and our toes. So we're going to start with just one foot. We're going to stretch the toes really far away from each other, and then we're going to lift the big toe up independently of the other toes. And when you do this, it's important that we bring the big toe over towards the opposite foot, not towards the foot it comes from. Now this is also a bunion exercise. So a lot of people, because of the pointy shoes they wear, their toe starts to pull in towards the foot that it belongs to, creating space. And that space then gets filled with bone and creates issues. So this is another exercise I do a lot with them. Then we're going to lift all our toes up, and we're going to place just the big toe down. When you place the big toe down, you're going to press it lightly into the floor, and again, feel like you're pulling it towards the opposite foot. Then you're going to lift all the toes up and place just the little toe down. Now when you place the little toe down, make sure you're not tightening your knees. If you've had to roll your foot over to get the little toe down, keep the little toe down and roll your foot back. Then you're going to lift all your toes and place your big toe and your little toe down, keeping your middle three up. Yeah, it makes you feel a bit icky sometimes to shake it off. Let's do the other foot. So same thing on the other foot. Stretch your toes nice and wide and then lift just the big toe up. And then lift all the toes up and then place just the big toe down. And again, if you've actually rolled your foot over to get that big toe down, keep the big toe down and roll the foot back. Then lift all the toes up, place the little toe down, and then lift all the toes up and place the big toe down, and now the little toe down, and keep the middle three up. You can use your fingers if you need to for this exercise as well. Okay, down and shake off. Let's do both feet at the same time. So feet side by side. Lift both your big toes up, pulling them in towards each other. Then lift all your toes up and place your big toes down. Then lift all your toes up and place your little toes down. And then lift all your toes up and place your big toes and then your little toes down, keeping your middle three up if you can. Knees soft, make sure you haven't locked them out. Jaw soft, make sure you haven't tensed it. Hands soft, make sure they're not tense either. Good, then shake it off. And then last little one for this is we're going to do a little Mexican wave. So feet side by side again, knees soft, lift the big toe, and then you're going to try and individually lift each of the other toes one by one, slowly if you can, all the way to the little toe, and then go back from the little toe all the way to the big toe. Ta-da! Well done. So the sciatic nerve ends up, it's two branches. The sciatic nerve can be bifurcates at different places in your body. Some people it's right up here, some people it's down here, it's different places. It ends up in your big toe and your little toe, or branches of it. So it's not the actual sciatic nerve, but branches of it end up there. So the more mobile we can get our toes to be, hopefully the less likely you are to get sciatic issues, because we're allowing that flossing of the sciatic nerve through its branches. Then we're going to take the back of the dorsal part of our foot and we're going to place that on the floor. And so we're stretching again. This opening here at the ankle helps to open through the hip flexor. We want to make sure the heel is in line with the rest of the leg, so we haven't dropped the heel out towards one side. Watching all the bouncing, we're going to be bouncing in a minute. And then we're going to take a nice deep breath while we're here and then swap to the other side. So same thing on the other side, make sure you're not dropping the heel. Good. So this is a stretch that's rarely done in the body, but it's really good because it helps to open up into the pelvis at the beginning of the session. Excellent. Now, okay, now we come to that. Now what we're going to do is loosen our pelvis off a little. So again, what I've talked about is these tension patterns that women hold, and we want to try and warm it up, their pelvis up before we start. So we're going to bend our knees a little, and then all we're going to do is tilt our pelvis backwards and forwards. So it's just a tilt backwards and forwards to start with. I'll show you from the side because the next one might be a bit like, what are you doing? Good. And then now, once we've tilted, so this is a pattern they hold, this is a pattern we hold, and what this tilt is doing is it's helping us to release any tension in the back and start moving the pelvis in that plane. The next one, I'm going to come back to, knees are a little bit straighter but soft, and we're going to tilt forwards and backwards, forwards and backwards. So we're tilting from our pelvis, forwards and backwards, forwards and backwards. We're going to do another 2, 1, perfect. Then from here, we're going to move our pelvis to the side. So we're moving straight to the side, straight to the other side. You can do this with straight legs, or you can do it bending the leg that you're moving away from. Doesn't matter. So it's straight to the side. So let's push to the side, getting some movement into this pelvis. Okay, and we're going to do another 3, 2, 1. Now we're going to hike the pelvis up. So we're going to lift it. So this part of our pelvis is going to come up towards our armpit. So we're lifting it up, and then up, up, up. These are all the movements your pelvis can make, okay? Up and down, it should make when we're walking. Up, up. Another 2, 1. Come to standing side by side. So now what I'd like you to do is I'd like you to take your hands on the top of your pelvis, and I'd like you to push the right side forward and then the other side forward. So we're just pushing forwards. Push forwards the pelvis. So one side's pulling back as the other side's pulling forwards. Good, perfect. Nice. It's a little bit more movement in there. Good. Push that pelvis forward. Excellent. Okay. And then we're going to come back to the centre. Perfect. Now we're going to imagine our coccyx is going to draw a figure of 8 on the floor. So we're going to draw a figure of 8 with our coccyx. So you'll notice that as we do this, we go through all those movement patterns we've just done. The tuck, the tilt, a little bit of the hike, all of them drawing your figure of 8. Just get a little bit more movement into the pelvis. And now if you're going one way with your figure of 8, draw it the other way. So draw your figure of 8 the other way now. Good. That's where I always get confused. There's one way I really like and one way I don't like. So calming with your pelvis and your figure of 8. And now we're slowly going to make this figure of 8 smaller and smaller and smaller and smaller until it's a little tiny figure of 8. We've got that little oscillation in our pelvis, but we are at R neutral. So this is a nice balanced position. Good. Then we're going to take our rib cage. And first of all, the first thing we're going to do with our rib cage is we're going to lift one hand up into, oh no, we're going to use one arm. I forget what I'm doing. So we're just going to get the shoulder nice and relaxed. So just swinging. Good. So we want to feel like our arm is just swinging off our shoulder. Good. And then we're going to bring that arm and bring it up over the top of our head. And we're going to pat all the way around here where our rib cage is. Pat, 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 pat. Then we're going to inhale, and as we exhale, we're going to side bend to the side, still patting. And then we're going to inhale, come back to the top. And when you're ready for your next exhale, you're going to side bend again. And then you're going to come back. And you're going to side bend one more time here during your next exhale. And then come back to your inhale. And then you're going to allow the arm to swing again. And this time we're going to do the same inhale, exhale, but as we exhale, we're going to make this sound. So bring the arm up, start tapping, then inhale, side bend, then when you're ready to inhale, come back up and do one more, inhaling, side bending, come back up when you're ready, relax the arm down. Now take a breath. So inhale. And hopefully that side that we just released feels different than the side that you haven't. Thumbs up, thumbs down. How was that for you? Yay, brilliant, good. So let's swing the other arm, let's merge ourselves up because then we're going to go into our apneas. Good. Just really finding the pendulum motion in your arm. Perfect. Then arm up. Start tapping. We're going to do 3 over just on an exhale with no S. So whenever you're ready, you can inhale. And as you exhale, you're just going to be tapping all the way around this rib cage as you side bend. And then when you need to, you're going to inhale back to the start. And then when you're ready, you're going to exhale again. So just do it in your own speed. Don't follow me because obviously I'm talking. I'm probably not breathing very well. And then exhale over when you're ready. Good, really tapping all around here. You can get right into this kind of upper chest area as well. Then swing your arm again, find your pendulum. Good. And then bring it up and tap. And we're going to do 2 with the S. So inhaling and then and then when you're ready, you're inhaling back to the start and then exhaling back over. And back to the start and relax. And then take a breath and hopefully now it feels much freer to breathe. So we'll hopefully release any tension you might have. So standing here, feet hip distance apart, we find that balance in your pelvis again from your little figure of 8. I'm going to stand slightly sideways on so you can see what I'm going to do next. So knees are nice and soft. Our rib cage will be, if our pelvis is nice and neutral and we've done that swinging and breathing, our rib cage will be reasonably equally on top of our pelvis. We can take our hands, we want it to kind of be around about the rib cage on top of the pelvis, but for everybody, they've got slightly different patterns. So as long as it's roughly there, it's great. We don't want to hold anything tight and stiff. So as much movement as we can. So those warm-ups are really great for getting us kind of in a good position with nice relaxed shoulders. So we're going to have soft knees. We're not bending our knees, we're just having soft knees here. Then we want to think about the head position. So we want to make sure that we want to try and think about drawing our head back so it's also balanced on top of our shoulders. Again, we don't want to be so tight that we start to sound like Darth Vader. You know what? You want to take it back so it's just a nice, relaxed kind of little bit of a stretch up the back of the neck. Then we want to start the active stretch in our body. So what we're going to do is we're going to feel our feet on the floor, underneath the big toe, underneath the little toe, and the heel, and the inside and the outside of the foot evenly weighted. Then what we're going to do is we're going to shift our balance point forward a little towards the balls of the feet, keeping our toes soft and keeping our heels in the floor and actively engaging into the floor. What this is doing is as we do that little balance point forward, we're creating a little active stretch through the posterior fascia chain of our body. Our posterior fascia chain starts underneath our heels, underneath our feet, comes all the way up through the back of our body, all the way over the top to our eyebrows at the front. So if we're standing in a neutral position, it's active but not super active. But if we just bring our balance point forward and tilt forward a little, we create that little bit of active stretch, which is what we're looking for. Now, taking your hands around your ribcage, relaxing your face, you're going to do 3 nice slow breaths and an apnea, or a rib stretch, the way we were learning at the start. So take your time nice and slowly. And as you exhale, just allow the ribs to slowly draw into the center. Good. Remember to keep your jaw relaxed, your eyes relaxed, your feet relaxed. At the end of your third one, you're going to close your mouth and nose, pause, and use whichever intervention you need to widen your ribs. And when you need to inhale, inhale. So you may find that that felt much, much different than it did when you were on the floor. And the reason for this is now your diaphragm is also working as a postural muscle. So it's also stabilizing you. So it's got another job to do. So it's working as a tonic breath muscle, but also as a phasic stabilizing muscle. Okay, so it's got 2 roles. So you might feel it's a little bit more effort when you're here and doing it. So let's do that again. So make sure those knees are soft. Find your little figure of 8 pelvis, your relaxed ribs, shift the weight forward, the balance point forward rather than weight. I don't know, I always say weight. And then we're going to do our 3 nice slow breaths here into your active rib stretch. And remember, it's just nice and relaxed for this breathing. Inhaling, widening to the sides, the back, that little bit of sternal movement. And exhale, allowing it to slowly draw back into the center. The end of the third one, you're just closing your mouth and nose, relaxing your jaw, relaxing your abdominals a little if you need to, and then slowly widening your rib cage. Okay, how did that feel in your bodies? Good. What's going on? Okay, good. Okay, so now we're going to add some arms. So our arms, the reason we use arms in hypopressives is one, they're part of the whole fascial and connective tissue system, but also as we move our arms from here all the way up through to here, we start to create more activation in our serratus. And as we move our arms up, our rib cage gets slowly further and further and further away from our pelvis. So that means we intensify the lift that we get during the apnea, and we also intensify the activation of the muscle chains and fascia chains when we do the breathing, just by moving our arms. So we're going to start with our hands down our sides of our trousers for our legs. And then what I'd like you to do is I'd like you to imagine that they're just hanging there, the way they did when we did some swinging. So just do another swing. And just let your pendulum get smaller and smaller and smaller until it's just hanging. So your arms are hanging. I don't want any tension in your arms. Hands down your sides of your legs. Then we're going to imagine that somebody's gently holding your arms down, but you're just going to push them up. So it's just a gentle move away, still feeling that kind of openness and looseness in your shoulders and the socket. Perfect. So we're just coming to about rocket shape. Then from here, we're going to twist from our wrists. So we're going to start with our wrists. We're going to twist from the distal point, from our wrists to our elbows and into the glenohumeral joint, still keeping that space there as we open through the top of the arm. So we're only coming round as far as the thumb pointing towards the ceiling. Don't come any further round, because what happens when we come further round, so if I'm here and I start to twist round and I keep coming further, I'm going to start eventually pressing my chest forward. So we're only going to come so that the thumbs point towards the ceiling. Good. So what we've done there is we've opened in the glenohumeral joint and we're starting to create an activation through the serratus and into the latimus dorsi muscle. Now, feel nice and loose in the shoulder. No tension in the shoulder sockets. I'd like you now to feel like you're reaching out through your little finger, as if your little finger's reaching slightly away. I'd like you also to make sure you're not locking your elbows, that your elbows are soft. This is an important cue for people who are hypermobile. And as you gaze straight ahead, I'd like you to be able to wiggle your fingers and see them in your peripheral vision. Perfect. Now, holding your arms like this, relax your jaw. 3 nice slow breaths and one of your apneas. Take your time, super slowly. Inhale, widening to the sides and behind, and exhale, releasing slowly. Good. 3 breaths. At the end of your third one, you're going to pause and slowly widen your ribs. As you widen your ribs, think about reaching the little fingers away because you'll get a little bit more activation. Good, then shake them off. How did that feel? Good. Okay, let's take it a little bit further up. We're doing it here and then we're going to go to supine and you're going to feel it in supine and then we'll mix and match some other poses in. So we're going to bring our hands again down the sides of our legs. You can do your little pendulum if you want, just so you feel that looseness in the shoulders. We're actively stretching, not tensioning. Then pull your hands away from your legs. Twist your hands, and the reason we twist from the distal and not the proximal point is if we twist from the proximal point, we'll tend to create a shortening in here or a tension in here. Whereas if we keep reaching away with the fingers and reach from the distal point, we want to continue to keep the space in here. This is our first position. This is our second position. So palms are facing forward still, soft elbows reaching out through that little finger. Your balance point's forward, your toes are relaxed, your heels are growing into the floor, your head is moving towards the ceiling, you're relaxing your jaw. 3 breaths here, take your time. Inhale nice and wide with the ribs. Exhale, allowing them to drift slowly back down, just controlling their descent. And another one, so 3 breaths. And at the end of your third one, you're going to pause. And when you get there, slowly widen the ribs. And to help with the widening of the ribs, think about reaching through that little finger, keeping your elbows nice and soft. And as you do your apnea breath, I'd like you to think about your sacrum growing towards the floor as your head grows towards the ceiling. This will also help. And once you've done that one, you're going to shake them off. Good. So guys, try and make sure that your palms aren't facing up towards the ceiling. So it's not like when we do that twist in sitting in Pilates. Palms are facing towards the front. And the reason for this is as they twist around like this, for a lot of the population, what starts to happen with them, especially in standing, is their rib cage pops forward. And we want to keep this balance of the rib cage kind of balancing on top of the pelvis. Okay, third position. You can give them a shake off again. And then we're going to bring our hands to the sides of our bodies. Bring them out to a rocket. Twist from the distal wrist, elbow, shoulder. Bring it up to your T, and then bring it all the way up to wherever your V is. So bringing them up. You want to make sure here that you feel nice and comfortable in this position. Good. Palms will be facing forwards. We're making sure that our rib cage is still balanced nicely on top of our pelvis and we haven't thrust forwards. The weight still forward, the balance point is still forward on the balls of your feet, toes are relaxed, heels are engaged with the floor, head is reaching away. 3 breaths here and an apnea. As you inhale and exhale here, as you exhale, I'd like you to think about pressing through your left foot and reaching with your right hand, and at the same time pressing through your right foot and reaching with your left hand. So you've got this feeling of connecting the heels to the fingertips. So it's inhale and then exhale, reach. At the end of your third one, close your mouth and nose, pause, and widen your ribs. And when you need to inhale, inhale here, and exhale, relax it down. Take your time, finish your apnea. Good. Okay, so that's external rotation in the glenohumeral joint. We also do an internal rotation, and lots of my clients say, oh, but I'm internally rotated all the time. But they're not actually internally rotated all the time. They've drawn their shoulders forward into internal rotation, but not within the glenohumeral joint. So we can actually create a spread and a widening across here by creating a true internal rotation. So hands are going to go down the sides of our legs again. We're going to pull them out towards the side. We're going to rotate them initially so palms face forwards. Good. Thumbs pointing up towards ceiling as maximum. Then we're going to rotate, same as we did, wrist, elbow, shoulder, till palms are facing behind us this time. Then we're going to keep our elbows where they are and just bend them, and we're going to extend the wrists and bring them in towards each other. Good. So we've got this extension in the wrists as well. Yeah, perfect. So what we've done here is we've come from this position, we've started to floss the nerves and twist through the fascia. Fascia loves twisting. And then we started to tension the end of the nerve as we're bending the elbows, bringing ourselves into first position. Okay, so this is our first position here. Now I'd like you to think like you've got a hula hoop around the outside of here that you're just gently holding in place all the time. You shift your balance point forward. Good. And again, it's just gently holding the hula hoop. Don't, no tension, just an active stretch through these muscles. 3 breaths in an apnea here. Take your time, nice and slowly. Good, these all look really nice. So the rotation is always just within that glenohumeral joint. We're not rolling forward like this, which is what I see with a lot of clients. Good. And when you finish that one, give your hands a shake off, shake the bones in your hands and shake your shoulders. But take your time with your apnea. Okay, so a word about this internal rotation when you get there. Nice apneas, ladies. When we do this internal rotation, we want to be aware that we want to keep this area as wide as the area behind us, the shoulders. So if we bring our fingers too close in, which a lot of my ladies do, can you feel how it starts to tighten across here? So if you rotate in, and then I'd like you to bring your fingertips in towards each other, and can you feel how you get this tightening in here, and a bit of tightening in the back of your neck? I'd like you to widen your hands to the point where you can feel your shoulder blades being nice and wide, and it being nice and wide across your pectorals. And this is your position, and everybody's slightly different. So roughly, usually for people, it's in line with their armpits, but not everybody. So you have to, it's one that they have to find for themselves. So this is first position. We're going to bring our hands up to second position. So second position is directly in front of us. So same thing, thinking about the hula hoop going all the way around. The balance points forward. Feeling that width across the thoracic area, the upper thoracic area and the back of your body. Good. 3 breaths in an apnea here. So now by just raising our arms like this, we've actually started to create more activation in the serratus. Relax your jaw, relax your toes, relax your knees. The shift forward is from our feet rather than our upper body, so make sure that there's no leaning forward or pushing forward with the pelvis. It's literally rolling slightly forward with the balls of our feet. Good. 3 breaths in an apnea here. Shake it off. Give your hands a nice shake off. Your shoulders. Okay. Sophia.
Sorry, I keep asking questions.
No, please.
When I do it, obviously you're trying to widen the rib cage, right? But it's almost like you're not trying to take a breath, but your breathing is being affected because you're trying to push out. Your breathing is you're breathing, but it almost feels like you're almost vacuuming out the air inside. Am I doing it completely wrong?
Yeah. So if you're feeling a vacuum, great, Sophia. That's perfect.
It's almost like when you don't start to breathe, it's almost like you're not snorting, but it's almost like the breath is so far down that it almost feels like you're about to snort. Does that make sense?
Yeah. So you're creating such a no, what's happening is you're creating such a vacuum that the epiglottis is drawing down so much that when you come to inhale at the end of the apnea, it can feel like a, kind of, that kind of feeling.
Yes.
So just before you inhale, you can do a little swallow.
Okay.
So, or you can move your head from side to side just once or twice, and that will relieve that vacuum a little bit before you take your inhale.
Okay.
Yep.
Okay. So
Good
I wasn't sure if I was kind of just, I don't know. I wasn't sure if I was doing it right at all. So that's why I just wanted to double check.
Yeah, that's right. So if people get a big vacuum, what can happen sometimes, not with everybody, is that they can get this real feeling of like a suction in this area here.
Yeah.
So so when you come to breathe, we just want to release that a little bit before we breathe. Not everybody gets it. Some people do. But yeah, it's something glad you're here to ask that question. So I covered it. Yeah. Any other questions just now for that one? Yes.
Abby, I don't know if I missed it, but I'm not quite sure why we're rocking forward.
You're rocking forward because you're activating the posterior fascia chain.
Oh, yes, that was a dorsiflexion.
Yeah, so we're doing dorsiflexion and standing. Yeah.
Thank you.
That's okay. We're doing dorsiflexion to activate the posterior chain, but as we dorsiflex again, we're also getting that pre-activation of the deep transverse as well. Just the other one. Third position. I've not forgotten. So hands down the sides of your legs. Draw them out towards the side. Rotate them externally first, so you've got that feeling. Then we can rotate the wrist, the elbow, and then into the glenohumeral joint into first. Then, making sure our pelvis feels nice and balanced in the center and our ribcage balanced on top, we're going to slowly move our hands up through second, and then we're going to move them up to third. Now, everybody's third is different. What we want to do is we want to make sure we're moving them up and keeping the shoulders feeling nice and free. If we get to here and we start to want to thrust our ribcage out, that's our third. If we can bring them all the way over the top of our head, then that's great too. Everybody's slightly different. Make sure your balance point's over the ball of your feet, your toes are relaxed. Relax your jaw. 3 breaths and an apnea here. Remember when I said reach from the opposite foot to the opposite hand when we had our arms extended? Try that here. Think about that reach coming right through the back of your thoracolumbar fascia. It's that big bit of fascia in your lower spine. Almost like your human X, but obviously internally rotated. So 3 breaths here, and then your apnea. Good. And then shake it off once you've done. Okay, for me, this was a great way for me to teach you the arms, because in supine you can't really see what I'm up to. So, remembering, external rotation is 1, 2, 3. Internal rotation is 1, 2, 3. Now, I know it's a challenge to start off doing those with the apnea breath standing. So let's go down to the floor and have some fun with it on the floor. So I'm going to build the pose on the floor and talk you through what that pose looks like. I'm just going to angle my camera down a little bit.
Can I ask the apnea breath, when you're in the pause, I almost feel like I'm continuing the out breath, even so it's not a completely still breath. I feel like I'm still emptying my lungs, as it were. Is that right, or do I want to try and be really still? Does that make sense?
So when you're exhaling before you go into the apnea,
once I've exhaled into the apnea, and then I'm trying to spread my ribs, it almost feels like I'm still trying to breathe out.
So it could be that you're sneaking air in when you're opening your rib cage, Amanda.
Okay. That sounds about right.
So yeah, so what quite often is a very natural response is that when people start to initially do the apnea breath and widen their rib cage, they sneak a little bit of air in, and then it feels like they could exhale. So we want to make sure that we hold, it's just practice, Amanda. You want to make sure that you're holding the air out even when you start opening the rib cage. If it's the other way around and you've done your exhale and you go to open your rib cage and you feel that you could just exhale still, perhaps you haven't exhaled to the end of your natural exhale fully before you start your apnea. So try both in supine and see how they work. Try just making sure that you're holding the air out as well. But people do sneak air in without realising it.
Yeah, I think that's what I'm doing. Trying to get though.
Yeah.
Okay. Also, when you do the apnea and you then expand your ribs, I'm not consciously doing it, but I just feel my tummy coming in a little.
Perfect. Yeah, so your abdominals will react to what you're doing with your rib cage. The really important thing is that you don't activate the ribs from the abdominals, that the ribs activate the body. Yeah.
Right.
Yeah. Catherine.
Abby, just a quick question.
No.
How long are we holding the apnea for? Is it as long as you can hold it, or?
It's as long as you can naturally hold it, so that when you inhale, you don't do this. That's good. I'll ruin my throat one of these days doing that. So I've got a client who holds and holds and holds and holds because she loves the feeling of it. And then the breath that she does afterwards, I mean, I do very few live classes now as group classes since COVID because everything kind of came online. But she used to do it in group classes and people would just be like terrified, you know. But yeah, so you want to be able to take a really lovely natural inhale afterwards because it all becomes a flow. So you do your 3 breaths in your apnea and then your next inhale takes you into your next set. 3 breaths in your apnea. Your next inhale takes you into your next set. So we should be able to flow 1 breath, 1 apnea into the next set of breaths. So that's what we're looking for. Generally, when I teach a group class, I count. So we might start with a count of 8 for the apnea and then go to 10 and then go to 12. We're looking for people to be able to hold an apnea breath for around between 10 and 15 seconds on average for them to actually get those slow twitch muscles going. Yeah. Hannah.
Possibly a bit of an obvious, daft question, but I'm assuming that the more one practices this, the easier it gets to coordinate and more movement you're going to get through your ribs.
Yeah, absolutely. This is all about practice. You know, we're doing stuff that's like really strange for most people's bodies to start with because we've had like either an incomplete breath or a slightly dysfunctional breath. And then I'm adding in arms, and then I'm asking you to do an apnea, and then I'm asking you to do weird things with your feet. You know, it's like driving a car. You know, you could eat a sandwich, drink a juice and drive and like not really remember what you've done. You know, I'm not sure that's a good thing, but that's what this should be coming out as well. And it's also really, this is why it's really good for anxiety and also for mindfulness, which is a bit of a buzzword, but for anxiety and all of these sorts of things, because you've got so much to focus on that you can only be here in this moment. And even once you've been doing it for years, you're still thinking about where you're going next, you know, so you're really in the moment of the exercise, which is why it makes it so kind of, mindful, meditative, better word. Yeah, cool. So we're going to come to lying down on our backs. We're going to come back to the first kind of position we were in, which is all my clients' favourite position, obviously, because it's supine. The least favourite is what we're doing next. So we want to, again, I like people to kind of fluidly find their neutral. So rocking backwards and forwards, rocking side to side until you find where the neutral pelvis is for you and your body. And with the rib cage on the floor, it really is, instead of thinking about all the lovely stuff we did standing, it's just making sure that the back of the rib cage is resting on the floor. And it's the same amount of weight as the pelvis associated with it. Same with the feet. Back of the head on the floor, using a block on your head if you need to. We're going to start with the legs. So we're going to take the legs far enough away so we have a kind of 45-degree angle in our legs, or a little bit more. There's a reason for this. The next thing I'm going to ask you to do is dorsiflex at the ankles. As you dorsiflex at the ankles, put them down just again for a moment. I'd like you to notice the point where you can feel your muscles kicking in. So it's like a dimmer switch in a room.
You don't want the lights on bright, you want them just dimmed. So just because we're going to hold this for a while. So we're not tightening the muscles so much, we want to start stretching them in an active way. So we're dorsiflexing at the ankles until you can sense the muscles starting to switch on. And that's where you're going to stop. Then we're going to add a little bit more. So that's starting to activate that anterior chain I talked about up through to the transverse. And that's what that study's about with the abdominal vacuum and the dorsiflexion. Now I'd like to activate that posterior chain again a little bit more. So I'd like you to imagine you've got two marshmallows, one underneath each heel. And you're just squishing the marshmallows gently to the floor. So you're not putting much effort in because marshmallows don't need much effort. They're squishy. So that's starting to activate that posterior chain a little bit more.
Abby, when you say when you feel the muscles activate, what muscles are you wanting to activate or feel activated?
So to be honest, it depends on how fit your person is or not person is, you know. So the initial thing you'll feel is the front of your shins, the muscle groups up here, drawing up the feet. But also, once you tune into it, you can actually feel the chain, the fascia and connective muscle chain underneath the heels starting to stretch lightly. So you've got an activation on both sides of the ankle. So yeah, good question. So as they tune in, they'll feel more and more. The squishing of the marshmallows is to start engaging more of the posterior chain. And then to add to that, without changing that lovely fluid kind of sitting position your pelvis is in and your lovely neutral spine, we're going to feel like we want to draw the heels back towards the sit bones gently, but with no movement. So it's just like a dimmer switch in a room. So you don't want to be pulling back so much that you start to anteriorly tilt your pelvis or affect your spine. It's just that light switching on. So you should, if you tune in, you can feel the hamstrings kicking in a bit, the glutes kicking in a bit. Now, adductors are super, super important for our pelvic floor, like super important. So I would like you to imagine you've got a little ball between your knees that you're holding in place. You're not squeezing it, you're just gently holding it there. So your adductors should be firing just a tiny bit. Good. Now, hanging here with all that leg stuff happening, just be aware that that's what's going on with your legs. Place your hands around your rib cage and do 3 nice slow breaths in an apnea here. Take your time. So tuning back into the apnea. Remember, it's ribs to the sides, behind and sternum. And then just allowing the reverse to just slowly close. And at the end of the third one, you're going to close your mouth and nose, pause, and then slowly widen your ribs. Perhaps you need to release your abdominals a bit before you widen your ribs. And then put your feet down for a minute when you finish. We're going to come back into it again. Great. Good apneas. Okay, so we're going to lightly dorsiflex the feet again. Squish marshmallows, draw heels back towards our sit bones, but with no movement. Again, gently, just lightly switching everything on. Hold the ball between your knees. You're going to take your hands and you're going to place them on the floor in a downwards V with your palms facing up towards the ceiling. It's great on the floor because we don't have to worry too much about where everything's going, because we can just say back of your hands on the floor, palms up towards the ceiling. I'd like you to feel your shoulder blades on the floor, and we want to have as much space between the shoulder blades as we can. We want to reach out through our little fingers. I'd like you to think about your sacrum moving towards your heels and your head moving away from you, and just be aware of that as you breathe. 3 nice slow breaths in an apnea here. Take your time with your breathing. And at the end of your third one, you're going to close your mouth and nose and pause. And slowly widen your ribs. As you inhale, your ribcage should be on the floor. As you exhale, your ribcage should be on the floor. And as you perform your apnea, your ribcage should be on the floor. Once you finish that breath, you're going to take your hands into your second position, so into your T, with your palms facing up towards the seat. Again, using the floor to help you relax, but also reaching out through your little finger to help that stretch. Check in with your legs. Check in that your sacrum's moving one way, your head's the other, and that your jaw's relaxed. 3 breaths in apnea here when you're ready. And then from there, once you've performed your apnea, you're going to move your hands up into your high V. So you're just slowly moving them up, making sure that the back of your ribcage stays beautifully, gently connected to the floor. Make sure we're still dorsiflexing at the ankles, we're still squishing marshmallows, we're still drawing our heels back, we're still holding a little ball between our knees, we're still relaxing our jaw. Every part of this is designed to stretch different parts of your fascia and muscle chains. Make sure your toes are still reasonably soft, give them a wiggle. We shouldn't be holding any tension in those tendons. Brilliant. When you need to inhale, inhale. And exhale, relax your feet back down again. Good. Nice apnea, yes, good. So this time we're going to go to internal rotation. So we're going to do the same thing we did when we were standing. Our palms are pointing towards the ceiling. We're going to rotate from the wrist to the elbow to the shoulder, then bend our elbows and point our fingertips in just across the front of our pelvis for position 1. Good. We want to make sure when we're in these positions that we create a beautiful kind of circle, like a hula hoop. So we want to make sure our elbows don't get too tight, that we've got this nice long, beautiful hula hoop shape. Good. For this one, we're going to dorsiflex those feet again. Squish the marshmallows. Draw the heels back lightly. Think about the sacrum going one way and the head the other. And for this one, I'd love you to do 3 nice slow breaths in an apnea in your first position. Then move your hands to your second position, still keeping that beautiful circle. 3 breaths in an apnea. Then 3 breaths in apnea, moving your hands to your third position. So just getting a little bit of a flow in with your breath work and your apneas. Good. I'm going to come over and check people while you do. So there should be no feeling of tension, just gently, actively stretching through your bodies. Good. Carol, if you take your feet a little bit further away, it won't be quite so sore through. Yeah, you'll find the dorsiflexion feels more comfortable. If we're too close up, the dorsiflexion can feel too tight. Make sure your palms are pointing away from you. So palms should be pointing away towards the ceiling in second position. That's it. Well done, Sue. Good. Good, and then shake it all off. How did that feel in your bodies once you finish? Take your time. Again, give your arms a shake off, give yourself a stretch. Yeah, strengthening our wrists as well, which makes it easier for us to open jars and stuff, seemingly. So, how did that feel, doing it as a little mini flow when you did it, girls?
Were we meant to be moving the arms to the next position on the in-breath that you just need to take to get to the next position?
So generally when I teach in a class, I generally move during the exhale, but you can move during the inhale. I've got trainers who love moving on the inhale. At level 1, when we're doing level 1, generally, we do our 3 breaths in our apnea, and then we inhale and exhale, move. At level 2, we do all sorts of moving our arms, which we'll do tomorrow, and in the fascia course, a little bit more movement, because there's more mobilization as we get further into the practice. But we've got so much to learn at the beginning that it's all kind of static, active stretch positions. And then when you're at level 3, we move during the apnea. Because we've got so many other things to do during the breath work. The apnea is the only time to move our arms generally, and our bodies. So
in third position, laying down, because you're so conscious of the ribs wanting to flare, to be there.
That's exactly what I was going to say. I found exactly the same. I found it much harder to do the apnea breath with the arms in third position, lying on the floor, trying to control the rib cage. I found that quite a bit harder.
Yeah,
I think it's just practice.
It's practice, but it's also because you've moved your rib cage so far up already that the apnea breath will feel less intense as well. You'll feel like almost like, oh, I can't open as well as I can when I'm in second position. But it's because the serratus has already opened your rib cage quite a lot already. You've already got that kind of start of that opening happening when you move your arms.
Trying to keep that same sense of weight through the heels, the pelvis, and the ribs is much harder though.
Yes, it is, and it definitely takes practice. I always start my clients on the floor so that they've got that reference, so they've got those landmark reference points. So this will be this pose is called Demeter, so they're all called after goddesses, but this one's called Demeter, and this is always the first one I do with people, especially if they're in a room with me. But I started you guys standing so I could teach you the arms easier. You know, it's a bit cruel. But yeah, any other questions before we move on and do another pose? Okay, so we're going to come up to standing again, actually. We're going to look at the hip hinge position because it's like the least well done, but one of the most important poses in lots of ways because there's so many references to everyday life in it. So we're going to do that. And then we're going to come down to the quadruped, and then we're going to come to our sitting pose for the final one. So, standing again, I'll turn on my camera a bit.
That was the need.
So this pose the standing poses have got 2 names. This pose here when we're like this is called Venus. This pose when we're like this is called Athena. Obviously you don't need to use the names, you can call them standing poses. However, it's good if you want to talk to each other about them because then you know what you're talking about. Otherwise it's which arms are you going to do? And we call these Athena arms, anything internal, and these Venus arms. So even if we're sitting and doing a different pose, Hestia, it's Hestia with Venus arms or Hestia with Athena arms. And it just means that we can easily talk to each other about what we're doing. So hip hinge. So we want to find that nice balance with our pelvis again, so a wee bit of a figure of 8 or a tilt. You want to feel that your rib cage feels like it's floating on top of the pelvis. Knees are soft, feet are hip distance apart. And then we want to shift the balance point forward onto the balls of the feet, keeping the heels connected to the floor. Good. And then I'd like you to think about your sacrum going one way and your head the other. Then from here, all we're going to do, keeping the knees soft, is we're going to push our bum out behind us. Now, the reason we're doing this, and it's sometimes easier to get a visual reference, I've discovered. If you imagine this is your posterior chain, of most of my posterior fascia chain going all the way up my body to here. So when we do our little lean forward, our little balance point forward, we're creating a little bit of stretch in it. When I come into my hip hinge, I'm creating more stretch in it. So I'm stretching all the way through. I'm opening my glutes up,
There's lots of reasons why this is great for women, especially glute clenchers. But I'm opening my glutes up, and I'm also, when I'm in this position, the femurs roll in slightly, the sit bones widen, so I'm stretching my pelvic floor. Now I'm showing you like this, because the one thing we're not going to do is do this, because that just creates loads of release in my band. I want a nice stretched posterior chain. Okay, so not squat. All we're doing is hip hinging. So you've got your beautiful alignment. Let's bring our hands internally rotated into Athena first position. We're going to push our bums out behind us and place our hands on the tops of our thighs. Yeah, they can be anywhere on the tops of your thighs. Perfect. And I'd like you to feel like you've really opened your glutes as you come down. Now this is a position people use for hoovering, loading dishwashers, everything. So they can practice this all the time. And it's such a great position to open that the pelvic outlet. So from here, making sure your balance point is forward, making sure you're still nice and wide across your shoulder girdle. We haven't curled in the way. Good. Check your knees are directly over your second toe or your feet. Perfect. Then 3 nice slow breaths and an apnea here. Face again, so thinking about eyes, where your eyes are about 1 meter in front of you. We want to have this nice, all we've done is kept our head on top of our shoulders and hip hinged. These are nice, 3 breaths and your apnea. And this pose is called Artemis. How did it feel? How does it feel?
Nice.
Good. So, things that can go wrong with this pose. Ladies that glute clench like this, when they try to come into the hip hinge position, they'll come in and they'll have this bony straight back that's just straight back here because they haven't let go of their glutes in order to get a nice neutral spine. So it's definitely a big one to watch out for, to make sure they're not still glute clenching. You know, so I've got a great cue I use for them. I've got this, I've nicked it off one of my trainers. She's called Kirsty Victoria, she's lovely. She gets them to imagine they've got an open drawer behind them. They've got a basket of washing in front of them. And they can't drop the basket of washing, they've got to keep it upright. And they're going to shut the drawer, but they can do it just by pushing their bum backwards. So she gets them to push the bum backwards to shut the drawer. Now their chest is in a great position because they haven't dropped their chest down when they come into the position. Bum's in a great position, chest is in a great position, then place their hands on the tops of their thighs. And this has been a game changer for a lot of my ladies because they've done that releasing of the glutes without even thinking about it. Stretching rather than releasing. They've elongated their glutes. So they're not holding it in contraction, they're eccentrically stretching. Yeah. You what?
This particular exercise, sorry, I haven't got the feeling. It's a lot harder work, isn't it?
Yes, it can be to start with, but the good thing about this one is we work through what are called loaded and unloaded poses and hypopressives. And it's not the way you think it is. So loaded is when the diaphragm is being most loaded by gravity. So standing poses, upright poses like this, are loaded. When we come to a hip hinge, our diaphragm is unloading. So it's not working quite so hard as a postural muscle. And this is also the position I want them to learn for when they have coughs. So when they're coughing, because when they cough, instead of doing this, I want them to do this, because what happens is as the cough comes through their system, as the pressure comes down, it's like taking a ball. If I dropped it from here, it would just fall straight down. And that's what happens with the cough standing up. It's just the pressure goes straight down. But if you drop a ball, roll a ball down a hill, down a slope, it slows it down. So it's the same for when they cough, for the pressure that happens in their bodies. So if they sit or stand and lean forward. So learning this opening of the glutes, this leaning forward, this eccentric lengthening of the pelvic floor is great for coughing. Yeah. But yes, it can be.
I'm naturally quite lordotic. I'm a lumbar. Have you got any useful cues? I was fighting with myself, you know, to kind of correct it, but not tense and in that hip hinge.
The washing basket one's quite a good one because it gets you in the right position to start with, so that you don't too much. But yeah, if you kind of then push your bum out, it's gonna. So it's about just bringing in much more awareness to the rib cage being in line with the pelvis all the time. And we always in hypopressives want to try and keep the rib cage so it's an equal distance away from the pelvis all the way around. I mean, I know it's kind of an imaginative thing because some people's rib cage comes all the way down to the back of their pelvis here. You know, it comes down really low, whereas others are quite high up. So it's kind of a visual thing, but we want to make sure that we're not pushing forwards, pushing this way or pushing back. And it's becoming more aware. It's difficult, Catherine, when you're so hypermobile. Yeah, and luckily that's not where I'm hypermobile, so, you know. But yeah, it's bringing awareness to it. And I guess head position as well, Catherine, if you can manage to think a metre in front of you and judge where your head's going to be, because the minute you start doing this, your head's going to start coming up as well. So being aware of your head position. Okay, so let's try that again and just make sure that we all know what it is before we move into the next ones. So make sure you've got your beautiful alignment first. We've always got that shift forward in all the standing poses, so always that little slide forwards. Basket washing, if you want to use that one, shut your drawer with your bum and just check that they have actually widened their thoracic outlet. And then gaze towards the floor, soft toes, soft knees. 3 breaths in an apnea. Try and think about breathing into the back of your body. That's a good cue to make this easier. So think about the expansion into the back of the body more in this position than you would in the others. You guys are coming tomorrow. I've got lots to practice before tomorrow. I'm only joking. I'll go over everything. It's fine. So that is an unloaded pose. And we always want to mix and match a loaded pose with an unloaded pose if you're doing a hyperpressive practice with your clients. We're wanting them to work all their different fascia chains. So we're going to go into 2 unloaded poses again in quadruped next. So we're coming down to a quadruped position. I think I'll face this way just now so the neck thing's going on. So we're in quadruped. We want to make sure, first of all, that our knees are directly underneath our hips and our hands are directly underneath our shoulders. So we're creating a beautiful little box. This position, by the way, is called Gaia. So we've actually got 3 poses here, but we're going to learn 2 today. So we're going to learn Gaia and Maya.
I'm just hesitating. I've had a knee replacement, so 4-point kneeling is, I can't stay there very long, so don't wait.
Okay, actually hold off, Amanda, because I'm going to give you something different to do. Do you have a wall nearby you could use?
A mirror, yeah.
Okay, I'm going to show you something different to do, so I'm going to show you the alternative. So if you want to watch this one, and then I'll show everybody the alternative afterwards for people that have knee issues. I've got a beautiful alternative. So if you watch this one, and the same principles are going to apply to the wall. So yeah, but just we won't be on our knees. So box shape to start with. I don't want you to do anything that's going to hurt you. Curl your toes underneath behind you to create that dorsiflexion.